Good morning, ladies and gentlemen. Please settle down. If you are in the hall or online joining us virtually, we're about to commence. So please sit down. Thank you. Ladies and gentlemen, we will honor the land first with the national anthem. So I invite you all to please arise as we play it on the screen for those who have not yet practiced. Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians all and proud to serve our sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace or battle honor, and this we count as gain. To hang on to our children a banner without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed. And so with peace and plenty, Nigeria may be blessed. Amen. You may sit. My name is Abimbola Adebakin. I'm the PR Secretary for the Healthcare Federation of Nigeria. I'm also the CEO Advantage Health Africa. I will be co-MC today alongside the Country Director for R4 Research for Development, Felix Obi. We will commence right away with a welcome address by Dr. Pamela Ajayi. I'd like her slides to come up, please. The President, Healthcare Federation of Nigeria. Please welcome Dr. Pamela Ajayi.
Good morning, Honorable Minister, Honorable Commissioners present, special guests, distinguished ladies and gentlemen. If you'll forgive me, I'm just waiting for my slides to come up and for the pointer to come to me. While we're waiting for them to come up, the information to come up, can I just say what a pleasure it is for us to have this meeting here today. We really sincerely appreciate our Honorable Minister and all specially invited guests for being here. What I intend to do in my welcome address is give an overview of who HFN is, because I understand we have currently over 300 people online. A lot of people are very, very interested in this, in our conversation today. And this, our dialogue, is something that people are very keen to know about. So here we are, starting by talking about who HFN is. HFN is an umbrella body. We're an apolitical, non-governmental organization, and we are driven by the need to support the achievement of universal health coverage through the activation of the private sector. We are a coalition of stakeholders, and we actually are an umbrella body. We represent doctors, nurses, physiotherapists. We represent IT. We represent pharmacists. We represent so many different aspects, not just of the medical profession, but anyone who is related to healthcare and does private work, practice private sector work. On our own exco, we even have a lawyer, because she does medical legal work. So, who are we? I would say that in the past, we have done a lot. And I wanted to take us back a bit, because COVID, even though it has gone for now, it's something that should never be forgotten. And we did a lot of work at that time, pulling together private sector for testing, and not just for testing, but our members were behind the first med center built, this landmark center that was built, and provided critical ITU beds, ventilators, etc., and were behind a lot of the medical care that was done there. We've been working assiduously for some time to achieve certain physical policies, and we're very happy to say we've worked for several years, starting in 2022, 2023. We've worked with Dr. Salma, we've worked with our Honorable Minister, we've worked with, we can see Dr. Abdu here. We've also worked with the customs and, pushing forward certain issues, particularly to do with this issue. And we are so excited and delighted by the executive order that has been brought out on healthcare, which has brought out so many of the issues that we've been advocating for so long. We appreciate our president, because he's a listening president. And not only is he a listening president and a president who cares about healthcare, but he has also put in place the right people. And again, I'd just like to appreciate our Minister of Health. I don't know if we can give him a round of applause for the amount of work that he has done since he has been in office. There we are, having a small tete-a-tete with him. And he has, been able to push so many initiatives which we're looking forward to hearing directly from him, from the horse's mouth, as it were. And not only have we worked with the federal government, we've also worked with the Lagos state government, as you can see below. And I'd also want to recognize Dr. Tomi Coker, the Commissioner of Health, Ogun State. You can see her on the screen. You can see her physically here. So we can, to appreciate her also for the work that we've been able to do with her over time. Sorry, this pointer doesn't seem to be cooperating anymore. We've had conferences in the past, and we also appreciate the people who have been at our conference. Next slide, please, because I don't know why it's not working. We had the Medic West Africa conference, where we were able to bring out issues particularly related to emergency care, and talking about unlocking the value chain at the emergency care conference. We've also, I don't know why it's going backwards now. It's we did this, the annual conference. Can we go forward, please? Next slide. Next slide. We've also done a lot of work with gender and youth empowerment in terms of the creation of the Women's Forum and working with the youth on a number of trainings, etc. Next slide, please. Next slide, please. And we want to say we're very happy that we received the recognition from government, and we are actually serving on various committees. Our members are representing HFN, so the top corner there you see Dr. Yemi Daudu at the Technical Working Group on Medical Lab and Regulation. We have myself on the Technical Working Group on the professionals in the diaspora. We have Dr. Shitabe, and we also have Dr. Tosin Rishawe, who's Mr. Tosin Rishawe, who is actually here today, who's representing us on the national health, the NHRFA committee. So, what have we done? We've done a number of things. The slides have skipped through, but I won't go back. We've met with NAFDAC over key issues to try and resolve key issues for our members, and have gotten significant commitments from NAFDAC to help improve the landscape, which include things to improve cardiac care and so on. Next slide, please. We also, this is the NHRFA, which I spoke about, where we have our members, key members, are part of this. This is a very exciting development for Nigeria, because it's something that we have, worked on as individuals, as organizations, but the issues of quality and quality in healthcare are key. There are 3 pillars on which universal health coverage stands on. One is access, the other is affordability, but the key one is quality. Next slide, please. Next slide. We have a number of partnerships. Next slide. Next slide. We have done a huge number of webinars. Next slide. And we have international engagements. Next slide. And we have gone all over the world trying to make sure of this, talking to diaspora, trying to ensure they return. Next slide. And here we are today at our dialogue. And what are we trying to do at this dialogue? Just recently, we were involved by the Ministry of Health. The Ministry of Health called us to engage in a health alignment tool. And that health alignment tool demonstrated to us, because we called in a huge number of our members to make sure that this was properly reviewed, and it showed how little the private sector actually knows about SWAP, about the National Health Renewal Initiative, and it was actually quite shocking. And this is the key, or the bottom line for us, and this is why we're here today. We want to know how SWAP works. What are the plans? We've been told there's one plan, there's one action, one budget, and one conversation. We don't know what that conversation is. And more importantly, we don't know how the private sector fits in to that conversation. We've been told there are billions of dollars being allocated, billions of dollars being loaned, billions of dollars flowing into the healthcare system. How does the private sector, are we not going to benefit from this in any way? Or are we going to benefit from it? How do we fit in? Questions that are often asked. The BHCPF is a very important tool, and it provides funding for primary health centers. We have a lot of private health centers that have been concessioned to the private sector. Do the funds that go in private primary healthcare sectors, does it go to them? Does it not go to them? How is it that the private sector fits in? Because we want to encourage more and more work and integration. And that was one of the key factors that we spoke about, bridging the gap between public and private sector. That's one of the things we drive for, because we serve just the one public. And so we want to know, how do we fit in? What is the plan? And I'm so happy that we have really the top level of healthcare in the country today, to address us. And we also want to appreciate all the people who have come in on our panels, all the specialists, all the experts. We have key people from areas like the Guild of Medical Directors, the Healthcare Providers Association of Nigeria, the Association of Association of National Medical Practitioners, the ANPMP. And we have all of them here today ready to discuss these issues and work out how the private sector fits in and how the private sector, more importantly, can support the great work that is being done in healthcare in Nigeria. Thank you very much.
Thank you, Madam President. Yeah, good morning, everyone. And once again, we welcome you to this policy dialogue. And more especially, we want to welcome all our online participants. Thank you for joining. We will now take the goodwill messages. First, we want to welcome Honorable Amos Gwamna Magaji, who is the chairman of the House Committee on Health Institutions. Please, let's make him comfortable with it. Please come over, sir, for your goodwill message, please.
Thank you very much. Good morning, ladies and gentlemen. The Honorable Minister of Health, Professor Alipate, every other distinguished invited guest here present, I welcome you here for this very important event. Dr. Pamela kept disturbing me to I believe she has done that to almost everybody. I had to cut short my trip just to arrive yesterday in order to be here. I believe I'm still even sleepy. The involvement of the private sector in health cannot be overemphasized. It's not possible that the federal government or the government agency alone will be able to drive health for Nigeria. This discussion, dialogue you are engaging today, it's what we actually started discussing during our legislative agenda. How to create an environment where the private sector will feel will be a key partner in the healthcare delivery system in Nigeria. And we're glad to be here today, to be part of this dialogue. I say Nigeria has never been lucky before, at least to, having key people in the healthcare sector that are determined, that are focused, that are visionary. And when you look across all the agency, of course, nothing happens without the government. The government sets the environment where key players act. And I keep saying it because maybe, Prof, people will be thinking, maybe you used to come and see me, but but I'm so happy because I've been in Committee of Health. This is the second assembly now, and I've been in key health sector, and I've seen a lot of shift. And if we will maintain the tempo, I believe that in near future, Nigeria will find herself where we are not where we ought to be, but it is certain that we are not where we used to be. And with the effort we are putting right now, I think very soon the dividends will begin to show in all sectors. So I want to thank you for this engagement. And let me say that when I was looking at the presentation, I saw that the committee being set up for National Health Facility Regulatory Agency. I said, I quickly checked. I said, is there a bill to that regard? And I said, I'm not aware. Then I just discovered that. So please, engagement like this, we need to, you need to carry the house. It becomes very, very easy when it comes to the legislative angle, so that by the time we start putting all flesh together, things will be much easier. Well, I've been away, so maybe that's the reason why I'm not aware of what many things happening, but I'm back now. So I want to thank you all, key people seated here. I believe that the personality I'm seeing here, even though I'm not able to call everybody by name, I know that with this, we can drive health to where it ought to be. I want to say thank you for the honor, thank you for the invitation, and I wish each and every one of us a fruitful deliberation here. God bless you.
Thank you so much, Honorable Magaji, for that welcome address. Thank you, sir, for the goodwill message, rather. Now, we want to welcome to the virtual podium Professor Ilona Kekbosh. She's not physically here, but she'll give her address online. Please, let's put her on.
Thank you very much. Can you see and hear me? Is it all right?
Yes, we do.
Thank you very much. Honorable Minister Pate, I of course wish I could be with you, but the timing didn't allow it this time. I hope it'll work another time. And dear Healthcare Federation of Nigeria, thank you very much for this invitation. We from the Digital Transformations for Health Lab are really delighted that the Healthcare Policy Dialogue put such a strong focus on digital transformation. We work closely with our partner Farm Access in Nigeria, and I've seen Njidi on the video, working with her and her organization to take this agenda forward in Nigeria and in other African countries in partnership with others around the world. Some of you will know that our Lancet Financial Times Commission report argued that the digital transformations call for a reimagining of public health and universal health coverage. And therefore, I think the opportunity is just fantastic, not just to digitalize the existing system, but to use this opportunity to transform health and healthcare. Because obviously the new technologies are not only changing how healthcare is delivered, they are changing our very notions of health and well-being. And therefore, we have proposed that digital transformations also be recognized as new determinants of health, for example, in relation to the digital divides and to mental health. And of course, you are already addressing the huge digital divides that exist in Nigeria in terms of access to digital devices and internet connectivity, which is growing fast, but which will need to be expanded if we want to create digital-first health systems. But at the same time, and this is an idea I want to leave with you as you discuss further, public health agencies around the world are beginning to issue guidance in relation to health and internet for children and young people in the face of concerns. So we would like to propose, based on the work we're doing together with Farm Access, that the Nigeria Digital Health Initiative also set up a special working group to include the public health dimensions of the digital transformation from the very start, something that we call the digital determinants of health. I'd like to leave two more points with you. At our lab, we work very, very closely with young people because their health and well-being is uniquely impacted by digital transformations, and of course they are the main users. And you of course know, and for us in this part of the world it's always a fascination that over half the Nigerians are under 19 years old. So they should be involved in shaping the development of a digital first health system. And we spoke with young Nigerians, we had several consultations, and they told us what was at the top of their agenda. At the top of their agenda is mental health, health insurance, and sexual and reproductive health and care. And they want more investment in their digital health literacy. So we would like to propose, as this discussion on universal health coverage on digitalization goes forward, that you include young Nigerians in your discussions. Maybe you have a special working group. I saw that the Healthcare Federation of Nigeria recently involved young people in their work. So possibly you can take this forward by involving young people in discussing the future of the healthcare system, and that will motivate possibly also for them to. And the last point I'd like to make is governance. You have put various mechanisms in place to improve the governance of digital health, governance, and draw your attention to some of the work we've done on data solidarity and a tool that we have developed to help access the public value of health data. We believe that this is critical. So we think that the efforts that you are undertaking to leverage digital technology, also in cooperation with the private sector, are absolutely critical, but they must not be undermined by health-harming digital practices in wider society. So we think that to address the broader digital determinants, we really encourage you to push for stronger governance of digital environments, and to put a very, very special focus on the health, well-being, and safety of young people, because that's the future of your country, that's the future of Nigeria. I wish you a very, very successful conference, and I so wish I could be there with you. Thank you very much.
Thank you, Professor. And we want to go ahead with continue with the goodwill messages. So in our agenda, you can see that we have Mr. Uche Amon, but Prof, like you know, he reached out to us last night that he's in Seattle, so he's unavoidably absent. So without further ado, we want to welcome the National President of Association of Local Governments of Nigeria, ALGON, for his goodwill message, or his representative. Oh, great. Please, can we make him welcome?
Thank you very much. First, I'd like to sincerely apologize for coming in late. This is because myself and Dr. Ben are just diving in from Lafia, where the Association of Local Government of Nigeria had its NEC meeting yesterday, running through the night, climaxing the early hours of this morning, that produced new leadership for the association. The national president, Meifata Aminu, just handed over early hours of this morning because his term as executive chairman of Lafia local government in Nasarawa State expired today. I'm glad to inform the room that Algon has a new national president in person of Engineer Abubakar from Katsina State. On this note, I'd like to recognize the presence of the Honorable Minister of Health. And I would like to remain at that because I'm not conversant with the protocol in the room. I'd like to crave the indulgence of the Honorable Minister and organizers of the event to please deliver a goodwill message on behalf of the President on established protocol. My name is Akala Samuel Gajere. I am the immediate past chairman, Karo Local Government Council of Nasarawa State, and I work as special advisor to the national president on special duties. This goodwill message I said is on behalf of the president. On behalf of the Association of Local Government of Nigeria, the umbrella body for all local government councils in Nigeria, I'd like to thank the Healthcare Federation of Nigeria and the partners for the invitation extended to Algon for this healthcare policy dialogue with the team private sector support for swap white in healthcare. On the 23rd of August, 2024, the Algon team, led by the national president, paid a courtesy visit to the coordinating Minister of Health and Social Welfare, where Algon pledged its commitment to the Nigeria Health Sector Renewal Investment Initiative through SWAP and implementation of its primary healthcare revitalization and operationalization program across the 774 local government councils in alignment with the Nigeria Health Sector Renewal Investment Initiative of one plan, one budget, one report, and one conservation. The Algon Primary Healthcare Revitalization and Operationalization Program will align with the national health policies under the SWAP agenda, ensure an elaborate best practice public health partnership programs through an effective governance system and a robust finance and accountability framework that would deliver quality primary healthcare services to people with no one left behind. The key focus of the Algon Primary Healthcare Revitalization and Operationalization Program is to, one, reposition primary healthcare as an entry point towards actualizing local government council autonomy with a leadership role and responsibility for primary healthcare service delivery at the local government level. Two, implement robust resource mobilization and management strategies that prioritizes health expenditure as an enabler for economic development and shared prosperity for all people across the country. Establish an effective partnership and strategic collaboration with the federal and state governments, private sector groups, development partners, multilateral organizations, civil society organizations, and the traditional rulers, amongst other stakeholders. Initiate and digitize primary healthcare services delivery system across the country, linked to central national health data system to track health trends, patterns, and progress across the country. Institute a capacity development, monitoring, evaluation system that will ensure a high-performing, well-motivated health workforce across the country. The Algon Primary Healthcare Revitalization and Operationalization Program envisions a well-coordinated and accelerated effort across the levels of government to strengthen healthcare system towards achieving the UN SDG goals by the year 2030. Ladies and gentlemen, I'd like to end the address of the President by saying that the local government remains the tier of government where every citizen of this country resides. I would like to take the liberty of this occasion to thank Mr. President for summoning the political will to salvage the local government councils in Nigeria. I'd like to also inform us that the local government are better positioned now to prioritize its budgeting system to improve healthcare delivery at the local government, which is the entry point for every Nigerian. I would like to also reiterate that the primary healthcare system is not for the less privileged, but for every citizen of Nigeria as an entry point to healthcare services in our nation. Thank you for the opportunity to join you in this room today, and I hope that the Almighty God bless our collective efforts. Thank you.
Thank you so much, Algon President. Before I welcome my co-anchor, I want to share a short story. In 2011, I was a co-editor of the Africa Health Journal, and I came with the editor-in-chief to visit Professor Pate when he was the Minister of State. Prof, I hope you remember that day. So when we got there, he had a chalk, a whiteboard, where he listed 4 key areas he will be focusing on as Minister of State. One of them was saving 1 million lives. Then I think the third one, out of the 4, I'm just picking 2, unlocking the potentials of the private sector for health. Prof, you remember? And within a short time, we had an amazing unlocking of the private sector for health. Private Sector Health Alliance for Nigeria was an offshoot of that vision. And one of his aides then, Dr. Muntaka, led that work. Prof, you remember? Now, we are in a new era, and I see this as a watershed moment, that we are envisioning a new period of reforms in the health sector, and we have another involvement of private sector, because this one is more like optimizing, taking the private sector to a higher level where we can be producing our vaccines and all. So it's interesting that today we are having this dialogue. In 2011, there was no opportunity to have this kind of dialogue because the private sector has not coalesced to this point. So it's really a great thing that we have you here, Prof. And I want to welcome my co-anchor to, please, you come and introduce Prof properly. Thank you.
Thank you. If I was to read the CV or resume for Professor, we will be here for a long time. To catch up with time, please join me in welcoming the Honorable Coordinating Minister of Health and Social Welfare, Professor Mohammed Ali Pate.
Thank you. Please sit down. Thank you very much. The honorable commissioners that are here, the leaders of federal parastatals, our esteemed visitors, distinguished captains of the healthcare industry, I think there are several of you, Pamela, and members of the Healthcare Federation, other development partners, members of the press, good morning to you all. So thank you very much for really organizing this, Pamela. I think it's a long overdue conversation. You've had a series of conversations. This is one more. I also want to acknowledge Ilona. It's great to see you even online, and that you've kept a close interest in terms of Nigeria's journey towards universal health coverage. So thank you for your remarks as well. Now, this is themed health policy dialogue. So the conversation is a policy dialogue. I expected a round table. I didn't expect to be reading a speech, and I don't intend to do that. Pamela, I've acknowledged your leadership and all the leadership of the HFN. I think you've been you've been tireless. Felix, R4D, I think you've been amazing over time. You've kept the light going for a very long time, and I think we've come to a point where, as you said, there's a possibility that we can do something really profound in Nigeria's health sector. So thank you for all your leadership. A few, maybe more than 20 years ago, as a young public health physician, I decided to go to the other side to understand the private sector. So I went to a business school to understand finance, economics, and really how the business sector works so that we can optimize it. I didn't know that I would find myself in this position now, but it's really a very important conversation given the mixed health system that Nigeria has. And my team, which is a great blessing to have really good people, had prepared me, and Right Honorable, my boss is here, the Honorable Chairman of the House Committee who is here. He knows all the things that he's asking me to do. I've got a great team that is helping me prepare for all that I do. So I acknowledge him. They prepared some notes for me, thinking that I'll come and give a speech. I will respect them, I will keep the notes, but I will actually want to have a dialogue with you. I want to reflect because I do have questions myself. You are the private sector leaders. There are commissioners of health. We've got a member of legislature, and there are others who are experts. So let's make it a dialogue. I wonder how many economists are in the room. Trained economists, not armchair economists like me. How many trained economists are here? One trained economist. Anyone else? Another one over there. Okay. 3. Vivian. Okay. So I can take liberties because I'm not an economist, so I can pretend to be one. One of the questions that I have is, in a mixed health system that we have here in Nigeria, like many countries, what is the role of the public? What is the role of public sector and public finance? The money that we put. Pamela mentioned huge amounts of resources. Why and what's the role? I think there are a couple of self-evident reasons. Elena will say that health is a right for every citizen, so the government should fulfill that objective. And that there's an inherent value in the population being healthy for its own sake itself. And that for the prosperity that is in our future, a healthy population accumulates a human capital that will drive that economic growth over time. But the majority of what we do in health is also public good. I will say not all. For the economists, they understand what is a public good and what is a private good. A public good that is non-rival and also is non-exclusive, like infectious diseases, like protection of the environment. But there are some that is maybe closer to private. If you're thinking about plastic surgery, for instance, what is the role of the public finance in that realm? But majority of what we are dealing with here, you say that there are lots of reasons because there are public goods in health, even though not exclusively. And then there are significant market failures by just the nature of health, which makes it critical for government to intervene for the poorest and most vulnerable. So if that is the rationale for why the public sector government should intervene in a system that is mixed, that has public sector component and a private sector component. But how do you navigate that when you don't have enough resources? When you have 85 or less than $100 per capita that you spend on health. In the US, 12,000, 13,000, 14,000 per capita. In the UK, 4,000, 5,000 pounds per capita. Yet, we have $100 at least total health expenditure, or even if you're generous, say less than $150 per person. And of that, just about 70% is private. Only 30% is public by all levels of government, by also the development partners that are contributing. So majority of it, the majority of health spending in Nigeria is private. But it's not enough. So if you're in government, in the public, how do you deploy these limited resources to contend with this role that we articulated for a population of 220 million people? Do you devote it in areas that a few will benefit, or do you deploy it in what will benefit the most of the population? Do you deploy them in where it's most efficient, you'll get more health for what you are spending, or do you build big hospitals that actually have all the gadgets, but only a few people living in Abuja will benefit from it? And so in that context, what is the role of the private sector? What is the role of the private sector in that mixed health system? And what is the role of the government? I'm sorry, you may have come here looking for answers, but I'm actually putting questions that I also ask myself. So I think that's the country that we face. As a country, we're spending not enough because we're not collecting nearly enough in terms of government revenue relative to our GDP. We're one of the lowest in the world because we don't pay taxes. Okay, someone else. Can you mute, please? Yes. Who is holding this? Okay. So we don't spend enough because we don't really have enough of that revenue. And of what we spend, less than 40% is on primary health care at the base, which really reaches to the majority of the population, the poorest, the most vulnerable. And when you look at the financing, there are countries that spend as much or lower than us, but they have better outcomes. Ethiopia, even Niger, Ghana. So within what we spend, even if you come to the lower amount of spend, there's a performance gap. So what do you do with that? Then there's a hyper-fragmentation. Everyone doing his own little bits here and there. Development partners doing their own thing. Federal government doing its own thing. The agencies doing their own thing. States also doing their own thing. And then the private sector is essentially on its own as well, except with the latest efforts, HFN and many others that have come in to really organize it. So could that explain the underperformance that we're seeing? That we're not being efficient in how we're deploying our resources. That we're also not efficient in how we mobilize the resources to spend, because insurance coverage is still very low. Because much of the spending is private, but it's out of pocket. So for those who don't have pocket, they are priced out of the market. Because the mechanism for insurance for people to actually buy the financial protection is not in place. And so we have very inefficient mobilization, inadequate pooling of those resources, and how we purchase it has not been really well crafted. And that's perhaps one of the factors that explains this underperformance. This is the backdrop to this administration's health sector renewal investment initiative. The president said, we need hope agenda. His vision is that this is likely to be a prosperous country, but that prosperity is not for granted. It can go the other way. but we're betting on the fact that it can be a prosperous country because of its population, the energy, the resources that we have. And health is key to that prosperity. So within that, we laid out this blueprint, which is translating the objective of UHC to save lives in just simple terms. If you go to my village and say, I want to achieve universal health coverage, they will ask, universal health coverage of what? They have no idea what they are talking about. But if I tell them that it's to save lives, it's to reduce physical and financial pain, to produce health, and to do that for all Nigerians, I think it covers all the, translates UHC in language that even the ordinary person can understand. And the 4 pillars were, 1, to deal with the governance, to rationalize it, to have one North Star, a sense of direction where we're going, to respond to our citizens' needs. We had the People's Voices survey, which 2,500 Nigerians were interviewed by Ipsos to understand their perspective. These are ordinary Nigerians. What is their experience? The quality of what they've had? What are their expectations? So that instead of the health system working for itself, the health system should work for the people. So to reorient it to be more people-centered. Because you can have a system, whether at the global level or at the national level, that actually the system works to perpetuate itself. People are happy, just keep doing what they're doing. Versus it's serving the client, who is the Nigerian person. And so the People's Voice survey was one. So also bring coherence between different levels of government, the federal government, the state governments, local government. I'm very glad to hear Algon's remarks because we had a conversation with them. And to sign a compact, which we did on 12th of December between different levels of government and with our external partners to say, look, you don't come from wherever and tell us the priorities we should be focusing on. We should focus on the priorities of Nigerians and our priorities based on our limited resources, and then you support us to achieve them instead of the other way around, to have supranational influences telling us what we should think. That is the pillar on governance. To have stronger regulatory bodies, professional regulators, whether it's NAFDAC, whether it's Pharmaceutical Council, whether it's the MDCN, whether it's the Laboratory Science Council, to reposition them. But it's also a function of the professionals themselves, because a poorly regulated profession doesn't serve anybody's interest, including the professionals themselves, because you'll be well-trained, somebody will undercut you. That is part of governance. Transparency, accountability, the health fellows, the PFMOs, to engage with community leaders, religious leaders, traditional leaders. That is the pillar on governance that is so vital, especially in a fiscally decentralized system of government, where we had to engage with the state governors. We had to have matrices in terms of accountability. What are we working towards? Because without it, everyone is just going his or her way. And if you don't know where you're going, any road will take you there. So the governance part was to really create that North Star and to align actors in a way that we move in that direction together in a mixed health system, which does not exclude the private sector, because private sector provides not only half of the services, but also almost everything else that happens, whether it's contract, it's private sector. Whether it's services, it's private sector. Whether it's the finance, whether it's the HMOs, all of that is actually the private sector. But how do they get governed properly in a mixed health system so the public mission is obtained and the private sector plays its part? When I say private sector, it's private for-profit and private non-profit. They have different motivations, but there's a public interest that has to be maintained to serve the interests of Nigeria. So that's the first pillar. And how we work with the legislature to raise the resources. I'm really have to say that we're very fortunate. I think Dr. Amos Magaji and his team at least have been very supportive with us. He in particular has been on the journey with us, patient with us, because we're taking a path that is not traditional. But many of them in the legislature have also been very helpful in that direction and will continue to do that. The second pillar is to focus on population health outcomes. We could say improve health systems. But in the context of Nigeria, where we're a young population, where we have the fastest growing segment of our burden of diseases, non-communicable diseases. Prevention is a key part of it. There are lots of things that happen outside the health sector that influence what happens in terms of population health outcomes, whether it's nutrition, whether it's girl-child education, whether it's water and sanitation. So many elements that are to contribute to population health outcomes. And then the healthcare system itself, with primary healthcare at the base. And with Algon expanding the primary healthcare, making it functional, the revitalization agenda, to work with the states, to raise the resources, to make them functional, the retail outlets to be available, to retrain the frontline health workers, which we said we will retrain 120,000, of which 40,000 have already been retrained. And that is ongoing, and I'm sure you'll hear more from Dr. Mui later today. That is on the primary healthcare supply side. On the demand side, to expand the Vulnerable Groups Fund, and from NHIA, you'll hear some of the reforms that they are undertaking to accelerate Nigeria's progress, to improve the resource mobilization and the pooling mechanism, and also the purchasing, the reforms that the NHIA has been doing, along with the HMOs and various providers, the private sector, increasing the tariffs so that they're actually compensated. Not easy. The use of technology, even within the context of NHIA. The e-NHIA that has been sold for many years, it appears it's not there, there's no there until now, and we can hear more about it from the NHIA. So to really do those hard elements on the demand side, on the affordability side as well. But that's not enough, because you cannot have a health system that is only on the basis of primary health care. There are referrals, there are emergency obstetric conditions that require cesarean section. You need higher level care. You need sophisticated specialist services in the teaching hospital. So revamping that, especially with cancers that we're facing. So there are two aspects: expanding the infrastructure and equipment, but also deploying public-private partnerships. You must have heard about the major public-private partnership undertaking that is being, now the full business case has been developed. There are several PPPs in many of our teaching hospitals. Some are boutique PPPs, some are more comprehensive, that are in various stages of development, so that we can leverage private capital, private expertise to deliver services. Not just talk about it, actually do it, because the advantage of the private sector is they can get things done. In many countries, the private sector is the one that builds hospitals. So bring that for cancer, for dialysis, for diagnostics, and also public partnership. NSIA is a national sovereign wealth fund, and it's owned by federal government, states, and local government. There's no individual shareholder. But we're using that as a vehicle to invest in the medical equipment. So the 6 cancer centers and the 10 major infrastructural projects that were, the groundbreaking took place, and Right Honorable Amos Magaji was with us. 10 of them within a single day, 8 diagnostic centers and 2 oncology centers. The cancer centers will start to be opening from May 2025, and the diagnostic centers will, the work is already underway. It's not talking about it, it's actually doing it. So, and they will be managed through NSA, even though it's private sector expertise, but it's public owned. So it's not, there will be, they make profit, but it's to government. But there's a discipline of the private sector that is brought into it. So then there are other elements of human resources policies, the managed migration policy, the doubling of the health workforce, medical schools, pharmacy schools, nursing schools, working with education to see that the standards don't get lowered. All those elements are also key, and many other policy instruments to ensure that we address in a really significant way what is needed to improve population health outcomes. Because whatever you accomplish, even if everybody is covered with health insurance, if the health outcomes are not getting better, if life expectancy isn't getting better, if mortality, then what are we doing? And the quality of care itself, and Felix mentioned, it's one of the pillars that we had clinical governance in 2011. It's now back on the agenda. We now have a scorecard for our teaching hospitals, and there are many associations. I know that the Society for Quality Health in Nigeria is here, and many others we'll find our way to improve the matrices for measuring quality, because if you don't measure quality, you cannot just assume it. So that's part of the effort to improve access and quality to improve population health outcomes. So if you take anything from this on the healthcare side, it's access and quality that will improve population health outcomes. Access to poor quality health system will not improve health outcomes. A quality health system that nobody has access to will not also improve health outcomes. So you need both. And that requires public investments. It also requires private sector investments. And at this moment, there are countless numbers of public-private initiatives in almost all our teaching hospitals that are engaging with the private sector, but they are doing things. And so I'll leave that second pillar there. The third element is the healthcare value chain, which is one that is building on the previous experience that we had, which was based on really very thorough diagnostic of the sector. We are very entrepreneurial people. There's a value chain in health, and whether it's in Europe or the United States or other places, health is a major contributor to the GDP. But here we've been positioned as just recipients of products, consumers, but we don't produce. Generics, test kits, we don't produce them. Bed nets, we don't produce them. Syringes, needles, we don't produce them. And we just buy them. So we're traders and contractors. So the idea from the president was to see how we can actually change it so that health is also a contributor to economic development, because it is the case. In most OECD countries, it's about 10% of their GDP. So for a country our size, we have to be on that path. And science is the base for that. The research basis, so the research governance that my colleague Dr. Tunji Alausa has been working on, the ethics to ensure it's properly regulated, the clinical trials capacities. Yesterday I was in Oshun, where we saw the amazing work by Christian Happy at Redeemers, which was really is the best institute of genomics in the continent of Africa. In fact, it's got the whole human genome sequencer, 2 of them. But it has promise in terms of, imagine what it can do, not only diagnostics, surveillance, but also products that can be developed and intellectual property. And then the whole chain of producing the basic things, generic pharmaceuticals, test kits for HIV, for TB, for malaria. Why should we have Lassa fever, but test kits have to come from somewhere else? I mean, it's a global community, but at least there's something that we should also be contributing. And there's an economic value in that. So we are working on that. Medical equipment, digital technology, because I think there's a value chain in there as well. Health services, there are pure private place actors that are coming to invest to provide services for those who can afford it, whether to afford it at NSA or to go pure private, because they go to Dubai, they go to India, they go to other places and pay in private facilities. They don't go to public facilities in the UK. They pay a large premium. So if those are here, can we not get them? And I think it's beginning to happen. There are some before our time. Marcel Ruth in Lagos, a private entity for cancer, and the orthopedic facility that Dr. Oni has put in Lagos. And there are several others that are now on their way, diasporans who are willing to come and invest. That is part of the value chain, because they will create jobs, they will retain some of the foreign exchange in this very large country. We're a large country, so we need to deal with that. That's sort of the value chain. I'll leave it at that. The fourth element is the health security piece, because we cannot disconnect it from the overall effort of safeguarding and the resilience of our health system. From really the surveillance, the core public health functions, the readiness to respond, the ability to deal with crises when they occur. And there is a public component to it, because it's public good, so you cannot rely on markets to deal with those directly. So there is a very clear mandate, let's say, for government to intervene. And I think we have to do more, not only as federal government, but states and local government, to pay attention So when we had diphtheria, we responded to it quickly. When meningitis happened, again, got vaccines and were able to deploy to stop it. Cholera, the same thing. Mpox. I think Nigeria is fairly done well, because otherwise these things will be on the front page. For the health security pillar, if the success, I believe it was the previous DG of NCD said, the success is in what does not happen. And people don't see it. Yet, it could have been a lot worse. If you look at just the cholera outbreak in Africa or even globally, hundreds of thousands of cases. For our size of country, it's been so far. I'm not saying that that's where it will end, and we are not letting our guards. Same thing with Mpox, same thing with all the various infectious diseases, and also even the ones that we have not seen. But it also has the private sector angle, because when there is a crisis, the private sector suffers. When Ebola hit Lagos, the Lagos market shut down. But how many private sector entities have their own preparedness plans for an infectious disease threat? What to do if there's Ebola, or if there is Marburg, or if there is influenza? How many private sector entities actually have a plan that they can actually take? So those are the elements that we're trying to bring back, including a strategic national stockpile. But the cross-cutting pillar in all of this is the digital transformation across from high-level services up to the primary healthcare. And I take Elena's point about the public health aspect. It's already on the way in a way, because we learned from COVID that you can use technology to surveillance, to ensure adherence to protocols for vaccination, for testing at point of entry. You can track, you can use many technological tools to strengthen your ability to respond from a public health perspective. But that's a cross-cutting issue across the 4 pillars. The defragmentation of the sector, when I talked about sector-wide approach, it's an approach. It's to defragment the sector from where we have no visibility. I will say that government may be inefficient in some ways, but believe you me, there are significant inefficiencies also in the external financial assistance for health, half of which goes to administration, planning, and all of that, versus front end, where the services need to be delivered. So how do we move from just workshops in Abuja, other places, and hotel bills and transportation and conference tourism to actually do what the people need? Pregnant women getting antenatal care, getting multiple micronutrient supplements, children getting vaccinated. If we do it on the things that matter to the people. So the sectoral approach is trying to bring everyone around that idea of one plan, one budget, one conversation, and one source of truth, including the data, instead of everyone sort of saying what is it that they want to use to justify their position. So we've now instituted a quarterly performance dialogue with the 36 states. For the first, we had a first quarter where we review the performance of the states across certain key indicators. The joint annual review will be done very soon, and I believe civil society has been very engaged. When we say civil society, we mean the non-governmental civil society, non-profit actors, but also the private sector in that sense. So I believe that there is enough room. It's a conversation that you cannot do it in isolation. But given the size of our country, the complexity of it, we've had many actors. Everyone is welcome to make a constructive input, not just to sit on the side and criticize or complain. But if you have a solution that you want to bring forth, this team, myself, the Honorable Minister of State, our heads of agencies are really solution-oriented. That's what the President wants us to do, and we're very much open. So when the joint review is done, you will have opportunities to weigh in, and then the state of the health report will come out. The first time in 10 years that Nigeria will have a state of health report, which will be an annual state of health report, which is provided for by the Health Act. So the sector-wide program, in essence, is not, we're just operationalizing what has been envisioned in the National Health Act. From the last time I was in government, that was the conception. How do we move towards performance, towards outcomes, towards coherence, less fragmentation? And now we are instituting it with different things, whether it's the policy anchors, like the Council on Health, which approved it in November, whether the Federal Executive Council approved it as a national policy, whether the President who approved it as national policy. So it's incontrovertible. It's now beyond just any individual. It's national policy. And so how do we collectively then bring ourselves to ensure we operationalize it, we execute it? So the resources that, Pamela, you mentioned, yes, we raised considerable resources. At the launch of the Health Sector Renewal Investment Initiative, just 12 December, the development partners led by the US government announced $3 billion commitment over the next 3 years in support of the government's program. That comprises some of what the Global Fund had, which they are moving towards the sector-wide program. They aren't fully in yet. You just heard about the World Bank HOPE project, which has been approved. This was a direct byproduct. It's not the World Bank saying what Nigeria should do. It's us saying what we wanted to do, and then having concessional financing to incentivize ourselves, states, local governments, to actually do what needs to be done. That's also part of it. There are grant financing. But what we did not want is a situation whereby resources get channeled largely through external actors that may be very well intended. I don't want to imply that every person who is working in health in Nigeria intends to do good. Nobody in health is trying to do anything not good. But it's just not necessarily the most efficient way that it's done. For instance, in a situation whereby you can have distortions of compensation. A young person who may be compensated this amount may actually have a different level of compensation, which essentially means people move from public sector to private sector, undermining. And the day the external financing disappears, then they are looking for the next job. But at the end of the day, the national systems will have to coexist and find a way to make sure that when the external financing goes, that the government also is there. If Honorable Amos Magaji is doing his budget and he doesn't know what the external actors are doing, he cannot factor in to think ahead and plan for when they are not there. Same thing with Ministry of Budget or Ministry of Finance or even us in Ministry of Health. So, but the more we have that conversation as to what are they doing, what is government doing, then we can hold each other accountable. Hold them accountable, hold ourselves accountable, for them to hold us accountable. But if they are sitting somewhere else, we don't have visibility, there can be duplication, wastage of resources, and that is not going to help us given the underperformance that we have. So in sum, that's the spirit of the sector. It's an approach to delivery, to reforming a health sector, to bring coherence to it, to achieve results, which is to improve the health outcomes of a population, and to do it in a collaborative manner that is inclusive. We are approaching this in a very collaborative manner. From the Federal Ministry of Health, I think we have a great team. My colleague and myself, the civil servants, the heads of agencies, civil society organizations. I think we've had many engagements with the civil society, some of whom are here. The private sector, even HFN, I think you showed it, that you've been in the conversation. It may not just be, let's say, called out, okay, or we may not put on the table. It's not transactional, basically. It's really a transformation journey. So it is within that, with that background that I just call on all of you to lean in, but to do what is necessary to make this system better. There is much more resource in health outside the public sector than in the public sector in Nigeria. So private capital has an important role to play. Entrepreneurs have an important role to play. Those who have investable ideas, they are willing to do the hard work to make it happen. there are resources that can be mobilized to support them. What will not be tenable is for, let's say, rent-seeking or just unproductive engagements. When we went, I see Dr. Tolu, to NSIA, we saw value. It's a public entity, but it operated like a private sector entity. There's a public value inherent in going that route. And we had savings of almost 30% by going to the original equipment manufacturers to buy the cancer equipment through NSIA. That's a large amount of money which we saved. On the other side, there are private sector actors who would have wished that 30% is the, what do they call it, the margin on the contract if we had followed the normal ways of doing it. But we did not go that way. So long as anyone external to Nigeria, within Nigeria, thinks of a solution, we're open to consider. Our view is not Nigeria in isolation, not the public sector in isolation, but Nigeria in the context of Africa and Nigeria in the context of the world. So that is the direction that we are going. So I would like to stop here. It's a dialogue, and I'll be happy to engage or separately have a conversation with you or my colleagues who will be here. They are much more informed on all of these matters, and they can take it from here. Thank you.
Okay, we'll take comments or very brief comments or questions from two people. One from this side of the room and one from that side of the room. We have one hand up over there at the back. Folake, please come forward. Then one from here. Anyone? No one. Okay. All right, please come forward. Okay. Since you're here first, please go ahead. Make it very brief.
Good morning, Honorable Minister. Good morning, everyone. My name is Regan Roland. I'm the founder and CEO of One Click Med. I'm in the private sector. We're building digital health products. Sir, I'm most grateful and honored to be here to hear from you firsthand on what the government is doing and how they're doing it. Sir, you mentioned during your speech that you're interested in the collaborative effort, in also supporting the private sector people that are doing stuff, not those who will just come and show off, but the one that are actually doing stuff. My question, sir, is how do you access these people? How do you know the ones that are doing stuff? How do you select them such that you're now able to help them push what they're doing in a way that it will benefit our country, Nigeria, and the people in general?
Okay.
Okay. Good morning, sir. My name is Folake Owodunni. I'm the co-founder and CEO of Emergency Response Africa. My question is about emergency medical services. It's something that doesn't get talked about quite a lot, but it plays a huge role in all of the outcomes that we're seeking to achieve as a nation. I would like to find out your perspective on how private sector players can be involved beyond just, buying an ambulance and seeking to get reimbursements from the emergency medical treatment gateway. Thank you.
Two absolutely brilliant questions, and I'm really glad that we're having this in the form of a dialogue rather than me coming to give a speech and then leave. So on the first question, the reason why we created this presidential initiative, the president created it, approved it, appointed a national coordinator to unlock the healthcare value chain. It straddles public sector, but it's also outside the public sector. It's a quasi-public entity with a national coordinator and a team. They are present, they've got a website, and they already have 40 business cases developed by entrepreneurs who have come and showed serious interest, have had the thought to say, okay, here's the problem, here's the solution, and here's the economics, and that it works in favor of an investment in that direction. Then they'll work with them to find how they can support them. There are others that go to teaching hospitals, to other providers within the system and engage with them. And there is a mechanism for that. Every day, I would say, 3, 4, 5 proposals come to my desk. And we look at them and we arbitrate. There's a difference between a solution looking for a problem and a problem looking for a solution. Sometimes folks create a solution, then they retrofit it and come to you and say, can government make this work? Because they see this is quantum of money, they will share and all of that. It's sort of trying to extract. So it's private sector, but it's entirely dependent on government patronage. That is not sustainable. So what we're looking for are entrepreneurial ideas that are market tested, economics actually works, there's demand for it, somebody is willing to pay for it. And then find the type of resource, whether it's grant or debt or equity, which is the way it is in most places. But to try to make it, what do they call it, nanny capitalism is not what we're trying to do, where you actually get your friend an idea that is not really viable, but because you have the opportunity to fund them, you fund them. But the day that you walk away, they basically get out of business. That's not where we're going. So to answer your question, if you have an excellent idea that will solve a problem, a real problem, then PVAC is the entry point, and there's a whole team that are from private sector and public sector that can look at it and can connect with other actors to help deploy that. That's on that. The question on the emergency medical services, there's a NE, it's a misnomer, it's National Emergency Medical Treatment Committee, and NEMSAS, and then the rural version of it, developed around the BHCPF and a gateway, which is to compensate for pay ambulances. This is what we inherited. We've inaugurated a committee to look at it. And I have to be very honest with you. We have 774 local governments. God knows we have probably tens of thousands of settlements and villages. I shudder to think of the day when the Ministry of Health is actually micromanaging ambulances in all of those places. It's just impossible. That's chaos. It's not really reasonable. So what we are hoping, and there are some commissioners here with us, and Simon is here. He worked very hard at the part of the MOC committee in terms of the compensation. But I think we need to step back. And at the next Council on Health, it's likely we'll come with a memo to say, look, can we formalize it into a service which coordinates for the federal government, sets standards, regulates, organizes the financing, but then have a diversity of implementers and states key into it, so that it's not at the micro project level, but federal government operates at macro level to set the stage for how emergency medical care can be provided. So private entities, I mean, Lagos has a much more developed ambulance service, and it's largely private sector. And in many countries, the emergency medical system is actually private, but it's based on standards, there's coordination, there's a way it's regulated, the capabilities are, and that has not been done, and we went towards just paying for the transportation. And so that's sort of a pivot that we are going to go in that going forward. And I think we would discuss it at the National Council on Health in November, very likely, and if the states agree, then to move in that direction. The blood transfusion system is another element that I think we also will pick up, linked to it, because the blood service is extraordinarily rudimentary in a sense. For trauma, for maternal cases, we have a blood service commission, but it's very underdeveloped. So we will work on repositioning it. I think through PVAC, they've been discussing with Zipline, which is already in 2 states in Nigeria, to see, okay, what is the model? Can Zipline play a role? I don't know, but at least we're looking at how to bring that to the fore as well. So those are the 2 elements that I would say in response to the question that were asked. So I'll have to leave.
Thank you
Pamela.
very much, sir.
Yes. Thank you.
Dr. Pamela has a comment, and then we'd like to take pictures with you just before you leave.
Okay.
All right.
Thank you. So Pamela, your comment.
Sorry, sir. Just wanted to make a special request. A lot of the decisions that are made and crystallized are done at the National Council of Health, and private sector is not represented there. Could we ask for the HFN to be a part of the National Council of Health, so at least we can contribute and participate, bringing in the private sector perspective and also carrying it back?
So let me just be very candid. I mean, you call this a dialogue, and I'm treating it as a dialogue. So some of the answers are straightforward, some are not straightforward, some are questions, and we can just continue to ruminate on them. So if you look at the National Health Act, Pamela, 2014, it's clear it created a national health system. That's what the law says, comprising the Federal Ministry of Health, the states, local governments, private sector, development partners, and civil society. So it lists what comprises a national health system. So by law, the composition of the health system includes the private sector. And the National Council on Health, that's why I'm speaking to you. Do you get me? Because you are part of the private sector. You are part of the national health system. And we, the Ministry of Health, we're the stewards of this system, whether it's public or private. And the Council on Health is the apex policy-making body. But when you come to involvement of actors who may also have conflicts of interest, there's a public mission, and there's, you have to find a way to ensure that the voices are heard, that they make their input, but that you have the right voices in the table or in the room. So I'll take this plea from HFN to my colleagues in the Secretariat of the Council on Health to put a mechanism to identify how the constituency of the private sector can be represented in conformity with what the law provides. Because if I pick HFN, tomorrow another private sector and say, oh, no, we are this federation of private sector, because you are a registered non-profit entity. The legitimacy that you have is by virtue of what your members mentioned to Corporate Affairs Commission and the Constitution. You're not representative of the entirety of the private sector in the country. Do you understand me? That the pharma industry, there are others, there are importers, there are others that are suppliers, that have very many dimensions of it. Now, are you representing everyone? So that's
actually, we are an umbrella body, and within us, we have all of these associations.
What I'm saying is, we'll look at the provisions of the law and have a robust guideline that ensures the representation. This is the norm. Even in global public-private partnerships, when you have a private sector constituency, there's a circumscription of who comprises that, and there's how the representation is derived at. If you were established by law, like SPHCDA, MPHCDA, that's one thing. Do you get me? Yeah. So, yes, you're a legal entity as HFN, but I cannot just, out of fiat, just say, okay, you come and sit, and not somebody else. But we will look at it, because you have built a track record over time. But there are also other actors that we have to look at how to construct the representation. If the private sector is not, and I think it is, because why I said that is, the first time I met with the pharmaceutical industry was at the Council on Health in Ekiti, in the context of the rising drug prices. When we talk about the emergency order, we got input from them. So they were at the Council on Health in Ekiti, and the Commissioner is here is telling you. So there were private sector actors in the room, development partners in the room, when we had those conversations. So in November, when I sat with the private sector, I called them up. It was in the Council on Health. So, but I will go and look at it, instead of making a public commitment and say, oh, HFN is part of that. That's the easiest thing. But that's not the right way to go about it. I will take that back to the ministry and look at how we strengthen the private sector voice in the Council on Health and the civil society as well. So thank you.
We'd like to take pictures with you. Dr. Pamela first, please. Up on stage. Then we will have all the dignitaries on the front row to please join them. No, for now. Just them for now. Please put the HFM backdrop. May we have Dr. Ashiru Abubakar, Dr. Ogbe Orise Waimi, and Dr. Yakubu Agada. Okay, Dr. Agada is up.
In place. So I'm not sure the value add to the presentation, because Professor Pate, the coordinating minister, had lucidly discussed sector-wide approach and the role of the private sector. But just to fulfill the righteousness, I will just move through the slides. And he mentioned he had a presentation that he didn't go through, but he just spoke off from his head. So maybe you'll just put your eyes to some of the conversations that he had mentioned, and I hope to finish within the next 10 minutes or so. So by name, I'm Dr. Ashur Adamu Abubakar, the technical assistant to the coordinating minister on SWAP governance, coordination, and state engagement from the SWAP office. So I'm representing the national coordinator, Dr. Muktaka Umar Sadiq, who is unavoidably absent. Okay, I mean, I won't waste much time. The coordinating minister had mentioned quite a number of these realities. The issues of inadequate funding for health in the country, and had discussed how we can, that beyond that we do not have enough, what we have is not equally giving us the good value for the money that we have. Issues of human resources for health, whether in their absolute number, competency, availability, and distribution. And then, of course, the quality of what they are able to produce. Issues of our health data, the fragmentation. Our data is not to be used, I mean, for a lot of a lot of discussions on, is it credible? Is it reliable for us to use it? And then, of course, the weak health infrastructure within the country. A couple of weeks or months ago, the National Primary Healthcare Development Agency completed an assessment of about 8,000 BHCPF facilities, and the results showed that less than 21%, or around 21% of the facilities meet the minimum service readiness. So that's a huge gap that we have. And of course, the fragmented supply chain that either end up giving us commodities or products that are substandard, or because of how long the supply chain is, ends up being more expensive, so that end users find it difficult to purchase. And then, of course, the hyper-fragmentation in government, the discoordination, which may impact on the lack of efficiency in usage of resources that we have, and then the regulation of regulatory products. And the truth is, the initial conversation by Dr. Pamela, the coordinating minister, the chair House Committee on Health, they've all mentioned that the role of private sector in healthcare can never be overemphasized. And across these weaknesses that we have, if we look through, you realize that really private sector had a lot to do to strengthening this. Next slide, please. So I think based on all this, with the leadership of the coordinating minister, a lot of conversations started, which he had mentioned, to make sure that we get, we focus our attention to what will really help to. Next slide, please. The pointer is not working. So, I mean, this is the architect, this is the framework for the Nigerian Health Sector Renewal Investment Initiative. And at the heart of it, really, you realize that one of the enablers that will help to drive this, the private sector, is there. Previous slide, please. And the minister spoke on issues of, I mean, building world-class health institutions, that the medical healthcare industrialization is largely going to be driven by the private sector. So within the context of the Nigerian Health Sector Renewal Investment Initiative, the role of the private sector is lucidly clear. Next slide. I won't go through this because the minister had discussed the framework of the health sector strategic blueprint, and I think that's where he took a lot of time to discuss with us what is the governance architecture that we need to put to make sure that we reduce the hyperfragmentation, we strengthen our regulatory processes, the efficiency in service delivery, whether it's healthcare worker availability, the training, I mean the expansion of the health insurance coverage, strengthening the healthcare, primary and secondary healthcare facilities, among others. And then, of course, the unlocking the value chain, which is aimed at repositioning Nigeria, and especially the health sector, to be a key driver of economic prosperity for the country. Next slide. And of course, the minister spoke about the compact that was signed between His Excellency Mr. President last year, December 12th, the state governors and some of the development partners, and then conversations are underway also to make sure that more stakeholders get into this compact, especially with the recent Supreme Court ruling to make sure that the local government areas also get added to this compact as soon as conversations are all concretized, and then many others that have not signed the compact at the beginning. And the compact is the one important tool that brings together all these entities to work to strengthen the national health system, as he described, that Federal Ministry of Health oversee, but then has the cross-representation from state, local government, private sector development partners, civil society, among others. Next. Before. So, I mean, the minister had discussed what sector-wide approach is, but just want to present, and he mentioned, and truly so, that it is not a program, because that's one misconception that we see a lot. People think SWAP is another program, but as the minister mentioned, SWAP is an approach. The reality is business as usual has not paid us well and has not given us the result that we want, that we look for as a country. And because of the initial weaknesses that we identified, it means if we really want to make a difference, we need to take an unusual approach. The sector-wide approach is that approach that we are bringing. And what does it really mean? It's saying government sets the priority and brings everybody together to align on those priorities, reduce fragmentation and discoordination, reduce transaction costs to the BRS minimum, improve allocative efficiency of resources so that we get more health for the money that we put in, among others. So that's really what the SWAB is all about, trying to make sure that we're all roaring in the same direction as a country and all the entities in there. Next slide. So there are key principles for the sector-wide. The minister had run through them quickly. The issue of one plan, one budget, one report, and one conversation. And for the one plan bit, we're saying those priorities, as I mentioned, government will set the priorities, and every entity within will now take those priorities to be the basis for the plans they will develop. And if I may elucidate a bit, at the moment, from September towards October, under the guidance and leadership of the coordinating minister, the Federal Ministry of Health and Social Welfare had finalized the health sector strategic blueprint. And as we speak, all the states in Nigeria and the federal agencies are working to have their 2025 annual operational plans based on those based on that blueprint. And with one budget, we're hoping that for the first time, we want to converge and ensure across all levels, across all states, that set of priority blueprint that are translated into the annual operational plan becomes the basis for health budget in the states. What we have before now is a situation whereby budgets are formulated separately. The plans for the states that are able to have partners to support also are done separately, and the two do not speak to one another. And if we cannot have congruence between the plan and the budgets, then that's a huge disconnect for us to be able to allocate our resources appropriately. So this year we are hopeful that this will be the case. We are on track. Already states have set up end of October as their timeline to make sure that all plans from facilities, local governments, and state levels are completed, and then that goes into the budgeting process so that we have some clear predictability as to what is it that we are planning for and what problems are we solving for at the subnational level. And then with one budget also, what we are really doing is ensuring that we are able to identify key gaps within the budgets, areas that are not resourced, and then work within the space to see how else can we bring in resources to fill in that vacuum. And then of course with the one report, whoever brings his money would want to see the result. But because we mentioned earlier that with one of our challenges is the data ecosystem is weak, and so everybody will people tend to quote data that best suits their needs. So part of what we are trying to do to solve that is to make sure that we standardize the data ecosystem. The minister had spoken about the One Source of Truth workshop, which was done and basically is for us as a country, agree what are the indicators that we want to track, how do we want to track them, how do we measure them, how do you use them, among other things. Next slide. These are some of the strategic, health sector priorities. Those that had the red edges or borders are those that you can clearly see the linkages that achieving them would not be possible if we do not have the private sector on board. Next slide. Next slide. So when you now go into the strategic blueprint, some of the investments the coordinating minister is bringing, you'll equally see that the private sector will play is an important catalyst to achieving both the supply and demand side areas listed here. And in my subsequent slide, I will just quickly highlight where are those areas. And importantly, because when Dr. Pamela was talking in the morning earlier, she mentioned that resources flew into the country through World Bank. So what are those resources and how do they link? How would the private sector link into them? Next slide. So apologies, this is a busy slide, but 2 weeks ago, the World Bank approved the HubGov project, which is $1.57 billion. 570 million is for the health sector, would come to the health sector. It will come as performance for result, program for results, sorry, and meaning for the entities, they will have to execute and then they get incentivized for it. A number of this, I've extracted few areas where the private sector can work very closely, either through public-private partnerships, also with the state, to make sure that these get executed. Key among this is the upgrade of facilities, both private and public, primary and secondary, to make sure that they meet the basic emergency obstetric and comprehensive emergency obstetric and newborn care standards. And importantly, the lever is to make sure that these facilities are climate sensitive, and that's an area that will need a lot of heavy investment from the public, from the private sector. But then, importantly, beyond, I think, the private sector engaging, doing the contracts, and providing the services, for the private sector, remember that when you come to think of your corporate social responsibility, please consider working to make sure that some of these facilities are upgraded as part of your corporate social responsibility to the country. Then issues of, expanding health insurance coverage, whether it's through the HMOs or the third-party administrators. There's about $40 million attached to that, which if there is a partnership between the state health insurance agencies or the national health insurance agencies, the private sector would benefit from these resources. And then, of course, the digital in health was discussed. Around $17.5 million is attached to there. And then expanding the HRH production, whether from building, expanding pre-service institutions, providing digital solution to expand trainings and what have you, among others. And then, of course, the referral system. About $40 million is pegged for strengthening and paying out for referrals of pregnant women, pregnant women and obstetric emergencies. And the NEMSAS Gateway have, in their guidelines, have equally made provisions such that private entities can latch into this for them to be used and they get paid to make sure that these referrals happen. And then, of course, the last but not the least on this slide, the issues of the local production of pharmaceutical products, among others, to just build a local production capacity. So these are just extracts from on what awaits the private sector in this financing facility that the coordinating minister had worked to get for the health sector, and a lot more. Last slide. This is the coordinating minister's plea to us. Through the Nigerian Health Sector Renewal Investment Initiative, there is no fence sitting. It's time for all of us to get involved. Thank you.
Thank you very much. do we have the pleasure of your slides, and can we share with all registered participants? Okay, that's fantastic. He's got very detailed content in those slides. We have one more session before tea break, and then we will have 3 panels, and then we'll wrap it up for the day. So all the way from Europe, he's flown several cities to get here, and we're so happy to have him. I think his profile should be on the screen. We have coming up to present an overview on healthcare transformation, Dr. Ricardo Baptista Late. He is the president of UNIT Parliamentarians Network for Global Health, and he's the CEO of Health AI. Please come up.
Good morning. Good morning. Okay, I had heard about Nigerian energy, but I wasn't feeling it there at the beginning. I'm so happy to be here and so grateful for the kind invitation. I asked our colleagues on the technical team if they could put up my slides. But while they do that, I want to start by thanking the Healthcare Federation of Nigeria, my dear friends Dr. Pamela and Najide for having me here. It's a real honor, and thank you for all of your hospitality. And it's been great. I've already been here for about 24 hours, but been to so many different meetings and events and hearing so many amazing things. Dr. Jane is here. We were yesterday at the launch of the Nigerian AI Collaborative, amazing initiative, seeing that energy, but also putting the human-centric approach and inclusivity at the center of the AI transformation that is so critical. So I was trying to wait for my slides. If I could get those, that would be great. So today I will be talking to you a bit about health system transformation and also then how we can adopt the power of technology and artificial intelligence for that, to accelerate that transformation. And I guess the slides are coming. We need an AI agent to help us out here. We've been asked for a minute for them to solve some technical issues.
Let me quickly sneak in and ask for some panelists to please come forward to fill up the seats. Irene. Moderators for the next session, Dr. Ogbe Orishawemi, Dr. Jennifer, yes please, Dr. Anne Ada Ogo,
Okay, well, I'm going to have to fly this one with no slides, so bear with me. I'm going to do my best to make this presentation. And so my background is as a medical doctor trained in infectious diseases. That was my first life. Then I was elected as a member of parliament. I served 4 terms in my home country of Portugal. I was also in local government. I was a deputy mayor. And then in 2017, I founded an NGO called the Unite Parliamentarians Network for Global Health. And so this is a network of current and former legislators from 112 countries committed to science-based policymaking, pushing for effective policies to help transform health systems. And more recently, last year, I moved to Geneva. I stepped down from politics to take on the role as CEO of Health AI, which is the global agency for responsible artificial intelligence in health, through which we are working with governments and the World Health Organization around the world to help build regulatory capacity, to build ecosystems that ensure that countries are capable of harnessing the potential of artificial intelligence and making sure that we can use AI to lead to better health outcomes, as your minister, Professor Pate, so importantly highlighted in his speech. And so the first part of my presentation is going to be about health system transformation, and then I'm going to quickly go through AI, and I know we're running late on time, so I'll try to make this quick and sweet. And I'm happy to take any question and to meet with you on the side also. So let's start by saying this. I come from the global north, and health systems from where I come from are completely broken. We are in a world where health systems should be called disease systems, because they simply react to when people get sick. And what this is leading to is to a rise of the burden of the disease. If people are getting sicker and sicker and we're pumping in more and more money in the health system, you don't need to be a genius to understand that this is not sustainable. You will hit a moment where health systems will not be able to deliver care to everyone. And so this idea of universal care is a fallacy. It will not work. And we have our slides here. Woo! Amazing job, guys. Now the clicker, I'll try to, no, the clicker is not moving, but anyway. I'll ask you guys if you can just go pressing it forward. You can press forward several times to get the, and so this is actually what I was saying, and you can stop here just to say, just one back, where we can see how the fact that we are seeing that universal health coverage is not possible because of the lack of sustainability of the system. Some people will always get care. People who have resources, people who are able to find solutions in the private sector or abroad. But the people who are worst off are the ones who are poor, the most vulnerable situations. And those are the people that without health are just going to get poorer and poorer, and their future generations are just going to get poorer and poorer. And so it's actually a vicious cycle, as you can see here. And every country, and I'm showing only rich countries here, the health costs are just going up and up. It's not sustainable. Next slide, please. And so to deal with this, we need to take a step back and look at what has been the origin of healthcare and medicine, at least from the very beginning, from prehistoric time, from the days of Hippocrates. And the truth is, healthcare was pretty simple. It was to promote health, preserve health, restore health when compromised, and minimize suffering and malaise. This was it. Next slide, please. But this was the reality until the 19th century, when the Industrial Revolution truly transformed the world. And as you can see, a lot of the things that we learned to do in the 19th century and the early 20th century, like mass production of cars, for example, and you can see here Model T from Ford, we still use those models of management today, as you can see on the right side. And so in the 1970s and the 1980s, some business schools around the world started looking at these models and saying, why don't we apply these models of management to health systems? And so if we can get the next slide, we can see how this led to what I call the industrialization of healthcare. And can I get the next slide, please? Yeah, there we go. And so basically it's an idea where the more consultations you provide, the more surgeries you deliver, the more exams you perform to your patients, the healthier the population will get. But the reality is that is not the case. What we are seeing is with this broken model focused on disease and focused exclusively on processes, instead of focusing on outcomes, we see that it is leading to the rise of burden of disease. The next slide, please. And so that's why Michael Porter, and you can press a few times so the different pop-ups can show up. Michael Porter from the Harvard Business School has said that business as usual in healthcare is over. And there are many reasons for that. Demographic pressure, the rising costs of innovation and technology. You can press a few more times. The social inequities, chronic diseases, the need for qualified healthcare work, a huge problem on the African continent, and increasing burden of disease. Next slide, please. And so since I have to speak a lot with politicians, I prefer to use cartoons. It makes my life easier. No, I'm just kidding. But it does help us pass the message on. And in this slide I was showing you, you could actually see a hospital, what I would call a modern hospital today in this disease-driven model, where it was basically having a factory. It's like a factory where there's a carrot. And that carrot is the incentives model, focusing on creating financial incentives to the health system based on performance indicators. So the more surgeries, the more consultations, the more visits, the more money the hospital gets. So I'm going to put this in very plain terms. If a hospital, if the people managing the healthcare system were capable of getting rid of all of the patients, of making everyone healthy, they would get less money. And so we're creating a financial and economic incentive to keep people sick. It's broken. And that cannot be our model of care. And so what Michael Porter and his team with the value-based healthcare approach proposed was actually to move the carrot to where the patient is. And it is possible, and this is a great example here from Portugal, where we can see how primary healthcare is actually changing. So very quickly on the left side, before I lose the slides, I'm going to use this. On the left side, you can see the primary healthcare model, which is what you call your classical model. So doctors, nurses, they all get a salary no matter what they do, right? And on the USFB there, the third column, is a new model of primary care where the state pays the doctors and nurses and so forth. They pay the health teams based on health outcomes. So if the patients actually get better. And what did we see? And both of these systems are working in parallel. So it's like a real-world trial. When we're looking at hypertension and diabetes, 35% of the patients have controlled hypertension here with the classical model where people get a salary no matter what they do. If you create an incentive based on health outcomes, you double the number of patients with hypertension control to 65%. Or if you look at diabetes, 37, 40% controlled diabetes in the classical model. If you put in incentives models for health outcomes, it goes up to 70%. So outcomes didn't matter, but creating a model of incentives matter. And we're talking about today, how do you bring together the private sector and the public sector to work together? And this is a way for the state to incentivize the whole system, be it public or private, to move in the direction of making your population healthier, spending the same money. It's just instead of putting the money in a black hole that you don't know what happens to that money, you are actually investing in true outcomes and knowing what you're getting out of it. So if we can get the next slide, where basically we can see that we have this model where basically today health outcomes are already a focus of a lot of discussions. And you can see here, this graph is really interesting. So here are the outcomes per country. And on the bottom here, on the x-axis, you can see the spending, how much countries are spending per capita in their country. And it's pretty easy to understand that when you have very weak outcomes in your country and you spend a little bit of money, the outcomes go up fast, right? Because there are so many needs. There's poverty, there's food issues. You're able to get results. However, when you reach to a highly efficient system like Singapore, no matter how much more money you put into the system, you can see there's a plateau. You don't get better health outcomes. And in the United States, it actually goes low, which is the country that spends most money interfacing their GDP in healthcare. And so the question is, why does this happen? And the reason is because it's a broken model. It's focused on disease. And if it's focused on disease, you will reach a plateau inevitably that no more money, no matter how much money you actually put in the system, you won't be getting a healthier population. You need to change your management model to focus on health outcomes, to focus on putting the patients, putting citizens front and center. And this is a huge opportunity for countries that are at the stage of where Nigeria is at, discussing precisely what is this model of the future. So if I can have the next few slides. And so I would actually argue that if we go beyond the current model of care, and if we go beyond the next slide, there we go, we can actually achieve more. But to answer all of these questions then, how do we know what actually works? We need to look at what actually affects people's health. What affects our health as individuals? The truth is, a doctor looking at their patient in the clinic, when I'm looking at a patient, I'm looking at 10% of what actually affects their health care. The clinical factors that brought them there. 30% are genomic factors. There are new treatments coming out for a more precision-like care, but these biological factors are harder to shift. 60% of what affects our health are exogenous factors. Our social status, where we live, where we work, the options we make, the behavioral options we make, all of this is affecting our health very directly. And the truth is, health systems are not looking at this from a holistic perspective. And so the next slide, please, because we need to make sure that we're looking at the different determinants of health when building up a model and creating the financial incentives to be able to do that. So if you'll see in the next slide, basically the carrot, that incentive that I was talking to you about, is actually one that instead of being inside a hospital, inside a clinic, the carrot, yeah, if I could get the next couple slides, please. Yeah, that carrot has to leave the health system, next one, and the carrot should be put within the community. And I want to stay just 5 seconds here to say that what I'm saying about this is really transforming health systems in a very radical way, but one that I truly believe can be impactful. It's creating the right incentives where you are paying managers, healthcare services, and so forth, not based on the indicators within a clinic or a hospital, but making the managers responsible for the health status of the people in a community. What I'm saying is that the state can actually hire the managers and the health system, be it private sector, public sector, social sector, and making sure that you have indicators to lower the burden of disease within the community. And you can use what I call CBOMs. Some people have told me that this acronym is not very good, but, but anyway, it's community-based outcome measurements. And what it is here is basically, I'm going to give you an example, diabetes, hypertension, HIV, you name it. You can actually pay the managers and pay the system saying, I want you to lower the incidence of new cases of these diseases by X amount in 5 years, and we will pay you a premium. And so you're actually mobilizing the whole system to go in that direction. And whoever is managing the health in that community will have to reach out to the businesses in that community. We'll have to reach out to the schools in that community, to the NGOs, to everyone, and have a whole systems approach. And this could be transformative, as I said, with the same money, achieving much better outcomes. So moving forward to the next slide, as I showed this slide, these are all the factors that influence our health. If I could press one more time on the button, all of these indicators here represent tons of data. And data is what fuels artificial intelligence. And you can see if we're generating this amount of data and we need to process this amount of data to build a new model of healthcare for the future that is focused on well-being and quality of life, then we need to use the power of artificial intelligence to address those challenges. So get the next slide, please. And so artificial intelligence is going to be transformative, and the market is growing exponentially. I mean, if in 2022 it was worth 11 billion just in healthcare, the artificial intelligence market in 2032 will be worth more than nearly $500 billion US, if not more. Next slide, please. And we're seeing startups growing up around the world. North America and China are playing a very important part. Europe is in between. But I highlight how low and middle income countries, how the continent of Africa is almost absent from this graph. And so we are always talking about the power of AI to be an equalizer, but we have to be careful because it can actually be the greatest divider of our time if we are not able to embrace this challenge. That's why the initiative yesterday of the Nigerian AI Collaborative is so important, because Africa needs to take the lead when it comes to artificial intelligence. Next slide, please, which will show us how this exponential growth is being translated in terms of patents. You can see here, these are patents just on AI. And the last international report shows that 61% of patents were produced in China. 21% were registered in the United States. Only 2% were from Europe and the UK. And I don't have to tell you, the rest of the world is not doing very well. And so if this is a proxy into the future, if this is a window of what the world will look like 5-10 years from now, we are moving towards a bipolar world between the US and China, and the rest of the world will be watching, and that cannot be the case. We need to invest more to make sure that regions that have the potential to leapfrog into the future, like Nigeria, can benefit from this transformative technology. Next slide, please. And we're seeing AI being applied in healthcare in every sector, from analytics, diagnostics, robotics, clinical trials, clinical decision support tools, cybersecurity, you name it. Next slide. It's really affecting the whole system. And you can see here how all of these big companies, Google, Microsoft, Amazon, they're all investing heavily in healthcare. And all of them are investing, for example, in what we call virtual scribes. The next slide, please. These are chatbots or even virtual bots that actually listen into our conversations and translate what we are writing or what we are speaking into electronic health records automatically. 70% of the time a patient is in a family doctor's office in the United Kingdom, they are looking to the back of a screen while the doctors are writing on a keyboard. We need to get the computers out of the room. We need to bring the patients and the doctors and the nurses and the healthcare workers closer together. And we can use technology to bring back that human factor. There was a study published last year in 2023 that actually used virtual chatbots, so written chatbots where patients could ask questions to medical doctors about their health. Half of the patients didn't know this, but half of the answers were given by real doctors, the other half were given by AI robots. What was interesting was that the machines, the robots, got much better health outcomes than the humans, okay? I wasn't surprised by that. But the funny thing was then a survey was done to the patients asking who showed most empathy and compassion. And the robots won. And I'll let that sink in for a second, right? The robots won. And you know why? Because they're not human. They don't get tired. They don't have to get their kids to school in the morning. They don't get hungry like you guys are before the tea break. I mean, right? I mean, machines are machines. They just can go on 24/7. So the question is, how do we rethink the place of the human in the health system? How do we transform health systems so we can use the machines to doing the boring tasks that we don't want to do, where machines are actually better than us, so we can bring back the human factor into healthcare? That, I think, is one of the greatest opportunities ahead of us. So if I can move forward, And Apple has done a deal with OpenAI, which created ChatGPT. So even people having Apple iPhones will be able to access a Siri that is already a bit like a virtual assistant. Next slide. And so this will be truly transformative. So a lot of people talk about the fear factor around AI, and we need to address that. But we also need to address the potential impact that artificial intelligence can have and use it and embrace it to transform our systems. Next slide. Because we're seeing healthcare is being affected by AI already. This is real world, where it's being used in every sector, either to improve health outcomes, to provide cost savings. I'll be happy to share these slides afterwards. And you can already see how AI is being used and how health systems are already trying to approach it. Next slide. But it is a bit of a Wild West out there, okay? And it's the Wild West because what we're seeing is a lot of companies selling AI tools, but nobody's really regulating, nobody's controlling. A lot of data is being extracted with no patient permission. Some people are calling this algorithmic colonization, where companies are coming into countries with no regulation and basically extracting the data. That data is worth money. That data is sovereign interest and sovereign security interest. And that needs to be addressed very seriously. Next challenge, next slide. So what a lot of countries have been trying to address is how do we build up a regulatory framework to deal with this, to make sure that we benefit from innovation, but keeping our citizens in our countries safe. And this is leading to tremendous fragmentation. We're seeing how the EU has the new AI Act, the AI law. President Biden in the US has his own executive order. A whole bunch of other countries are coming up with their own legislation. This is leading to tremendous fragmentation. It's small startup from Abuja or Lagos that are going to be ones suffering from a highly fragmented ecosystem because they won't have the capacity to adapt to the regulatory environment around the world. Moreover, this will slow progress of innovation and its impact. So next slide. So you can go through to show everything here. These are some of the challenges that we have identified at Health AI. The global fragmentation that I've already alluded to, the fact that AI is very fast in the way it's evolving, and so we need to make sure that we create systems that don't depend only on your national assembly or your government. You need to empower the regulators, give them the capacity to be able to keep up to pace with the technology, address data security and privacy, this is critical, and also putting in place post-market surveillance mechanisms. What I mean by this is even when you're using the AI in your health system, you need to continue to monitor to make sure that it is safe, especially in healthcare. Next slide. And so what we are doing at Health AI is precisely to help, through technical assistance, fix the governance of AI to make sure that we address those risks, but also build trust to accelerate adoption for better outcomes. Next slide. And to do that, we've looked at some examples in the past. And we looked at pharmaceuticals and the way regulations evolved. And thalidomide was a drug given in the 1950s to pregnant women to avoid nausea and vomiting. And this was done in a non-regulated world. And this led to more than 10,000 babies being born with birth defects because of this drug. Many more babies died. The silver lining of this global health tragedy, if I could get the next slide, is that it forced the world to look at regulation more seriously. Today, around the world, we regulate pharmaceutical products. No product can be sold in a country without clinical trials, without going through the regulator to get authorization to entry in the market. There's post-market surveillance if there are adverse effects to detect them early on. Next slide. We need exactly the same thing for artificial intelligence and machine learning for that whole life cycle. Next slide. And so when the computers, next, deal with your health, who's going to deal with the computers? And these are my 2 seconds of advertisement. That's Health AI as the global agency. So next slide, please. What we are doing as a nonprofit based in Geneva, working with WHO, who sits on our board, is being a bridge. And we work with governments around the world. We're hoping that Nigeria will join many other countries that are already part of this journey. And we're a bridge between the normative international standard setting organizations like the WHO, like UNESCO, like OECD and others that are developing standards and guidelines. And on the right side, you have your national and your regional regulators, the ones that your country, your government acknowledges. And what we help is with interpreting and translating those international guidelines and standards and adapting them to the local context and building up the regulatory capacity in the country so that the country can create an ecosystem that accelerates the adoption of safe, effective technologies based on AI for your health systems, and we certify the regulators around the world. Next slide, please. So very quickly, you can put the 4 boxes up. We are building and certifying the regulatory validation mechanisms to make sure that you can actually certify yourselves. As the minister was saying, you don't need some external body to do it. The country should be doing it. And with the power of AI, it's even more important to make sure that the national data sets are in line with the technology. We will be then connecting the regulators that are part of our network into one global regulatory network and putting in place a global early warning system. We're very excited about this. This is a system that if there's an AI tool here in Nigeria or in Brazil or in Singapore, in Switzerland, that has shown any risk or has caused any harm, all the regulators in the world in real time will get a red flag so we can avoid harm to citizens in real time. This is important for companies to avoid liability, but it's most important for citizens to make sure that they are kept safe and they can use AI in a way that they trust, and hopefully building up that trust. And with WHO, building a global public repository of AI solutions. So if there's a startup in Lagos, the first place they're going to be approved with their AI technology is in Nigeria. But as soon as they approve their startup technology, it'll appear on a global marketplace for everyone to see. It's a huge economic opportunity, but also for health system, those managing it, be it in private sector or public sector, will be able to go to the repository and see what technologies are out there that comply with responsible AI principles that you can adopt for your own country, and we will be providing advisory support tools. And next slide, please. Building up on all of that is, you can move to the next slide, is our community of practice. And so any institution that is interested in these discussions around ethics and regulations of AI and health can go on the link and apply to be part of the Health AI Community of Practice, where we're bringing together academic centers, NGOs, patient organizations, governmental representatives, regulators, everyone who is developing or affected by technologies, including the private sector developers, are being brought together by us in this community so that we can foster a discussion at a global level to make sure that we are applying the principles of inclusion, fairness, accountability in the development of an ecosystem that leads to better health outcomes for all, and accelerating the health system transformation and the leapfrogging that is at arm's length with the power of AI, making sure that we do that together, listening to people who are on the ground, who are affected by the technology. And so you're all invited, the institutions in Nigeria are invited to join. The government of Nigeria, we hope, will join, so that, and we can move to the next and last slide, so that together we can work towards a future in which we have better health for all ahead. Thank you very much.
Thank you so much. Wow. So there will be a time when AI will be treating us. Is that true? All right. Thank you so much. Really very insightful presentation. I know we've been sitting for too long. So it's time for us to have the tea break. And right after that, we go straight to the first panel discussion. So the tea break can now be served. I think because we are running, it's almost 12 noon, so we can do maybe like walking tea break, if that is possible. But while we are doing that, a couple of people joined us when the minister was around and other presentations. I want to acknowledge the presence of one of our elders in the health sector, Dr. Shehu Sule. We want to acknowledge you, sir. Yeah, a lot of all the health reform, he was at the Ministry of Health then. We also recognize the representative of the DG NHIA, Dr. Agada. We also have the representative of Dr. Mui, the CEO, that's the Executive Director of National Primary Healthcare Development Agency, Dr. Ogbe. I know, yes, he's here as well. I can see as well the former Director of Health Planning, Research and Statistics of Federal Ministry of Health, Dr. Ngozi Azodomama. We see you. Welcome. There are so many people. Dr. Amina, I can see you. And several others. You're all welcome. Let's quickly have the tea break. Maybe like 10 minutes to just grab, and then we come back to our seats and get ready for the panel discussion.
PVAC. We're going through a first round of private sector players in healthcare being presented to PVAC on October 21. We put up a robust system of identifying 12 private sector members of HFN, fully paid members. These are some of the benefits of being fully paid members of HFN. So on October 21, these members will be meeting with PVAC to present or to pitch their solutions, hopefully for some investment, and therefore they will be able to partake in the actual implementation that has been spoken about earlier today. We're expecting the Honorable Minister of State for Health, Dr. Tunji Alausa. He will be in the room shortly, but ahead of his presence, we will commence with panel 1. Remember, I mentioned that we have a little juggling. May I have one house? Thank you. Please shut the door. We have a little juggling of the panel sessions because we had committed to his presence here at 30 to lead a panel. He will be here, and his panel, the third panel, will be juxtaposed with panel 2. So we will commence panel 1 now and round it up in 45 minutes. I believe the moderator is committed to that. So permit me to bring onto the stage very quickly to address optimizing healthcare governance for effective policy implementation and resource utilization. The moderator for this panel is Dr. Jennifer Ayanti. Please welcome her. She's the Deputy Managing Director for Society for Family Health. We'll move this podium down. Please have your seats. That's moderator. Yes, sir. Giving an introductory keynote on behalf of Dr. Muyaina is Dr. Ogbe Orisheweyimi from the National Primary Healthcare Development Agency, NPHCDA. Please come on, sir. I'll get her. I want to... Joining the panel, who is the Director General, Delta State Contributory Health Commission. Please come up, sir. I'm also calling on to the Anne Ada, representing of the Private Sector Health Alliance of Nigeria, PSHAN. Please welcome her. Have a meet Ngozi Onya, who is the founder of Hospital. Dr. Onya, okay. A big round of applause. Then we, wow. And then we have Dr. Ben Kechika, Managing Director for the Almond Healthcare Services Limited and the consultant on health, Association of Local Government of Nigeria, ALCON. You're welcome, sir. I will hand over the microphone now to Dr. Ogbe.
Don't start with me. Don't start with Dr. Kobe. I'm waiting for him. Me too, I'm waiting for him. Oh, of course we are waiting for him to get back. Of course we are waiting for him to get back. I forgot we are all waiting for him.
Good afternoon, distinguished ladies and gentlemen. The President of Health Foundation of Nigeria, representatives of the Honorable Minister, DG CEOs, I will beg to stand on existing protocols because I know people have been in and out. My name is Dr. Jeremy Ogbe. I'll be standing in for Dr. Muyo Aino, the CEO of MPCA. We don't have a presentation because we'll follow the guidance of the Honorable Coordinating Minister. That is a dialogue. And so for the opening framing pitch, I'm just going to try to highlight a few randomly but connected issues as we look at the topic at hand, which is optimizing healthcare governance for effective policy implementation and resource utilization. And I think a lot of the things that are related to this have been spoken on earlier, but just to get going within a limited time we have, Dr. Muyi sends his apologies. So many things, appearances packed today from morning to the evening. So he had to concede that he could not be here, but really sends his best regards. So governance, I'm sure we all are clear what that is, but really, I think when we're talking of governance, particularly in the health sector, we're actually looking at those institutional arrangements that really outlines and establishes the rules and responsibility of everybody that has to do with delivering health for Nigerians. Most times this is always in fluid because we find out we have so many agencies, both at federal and state level, doing many things for health, and continuously there's always that conversation about who is responsible for what, whose mandate is what. And when there's no clarity in this, there's always a lot of inefficiency in how we implement programs and how we use resources. And now with the private sector coming in, and the conversation was even had this morning, is really that on how does the private sector come in, how do they get regulated, how do they play a role not just in delivering service but also in governance. And I think these are what the panel and other panels that will follow will really discuss. But these are really the things for us to hold in mind. So for governance, there has to also be the legal framework. And for us in the health sector now, the National Health Act remains the foundational framework on which we build everything we build. Even as of now, people are already calling for some aspects of the National Health Act to be restructured. But from experience, particularly from our elders who are present, we know that Nigeria, the challenge is never the law or the policy, but how we go about implementing it and interpreting it in a way that is selfless and addresses our goals. But I would like to say fundamentally, what governance is supposed to do is actually to enable us to effectively use information. And we saw a lot from AI today, and where lots of information that we can generate to make the decisions we need to make that are the right decisions, that we ensure accountability, value for money, and the outcomes we want for the health of our population. So let's look at that from that light, governance in that light. And also, how do we begin to promote the cooperation, particularly with the private sector, in terms of participation? How do we ensure transparency in what we do and how we make decisions? And above all of that, how do we also encourage accountability? So like the Honorable Coordinating Minister said today, the role of governance really, and his role as the head of the governance structure for health, is really just to print out the strategic direction, which during the SWOP presentation, we saw what the strategic direction is for the health sector. And I think the role of this meeting and this conference is actually to do some sense making. How does that strategic direction, how can we leverage the private sector to see to it that all of that is implemented and done? And for all of this, we've had a lot of issues over time relating to policy implementation and resource mobilization and all of that. But one of the fundamental problems that have always happened in governance is in three folds, in various levels. One is law, constitution, particularly when it comes to do with health. We've heard of things like concurrent lists, reclusive list and things of that about really who is responsible for health, and for where I'm sitting, who is responsible for primary health care. And so that is really where the governance really plays a role in determining who is responsible for what. In trying to solve that, we came up with different policies like primary health care under one roof, where we said, okay, the state, you are now responsible for primary health care and all ramifications. Bring everything for primary health care under the state. And that has been a long-term challenge we've been tackling, with some states doing exceedingly well and others lagging behind. And now, just as we thought we were getting that right, there are now emerging opportunities with the Supreme Court ruling for the local government health authorities. Local government by health policies responsible for primary health care delivery. How do we now cope with that? And how does the private sector come into all of this at the various levels? I think these are some of the things we really want to look at. So part of trying to resolve the issue of governance is also resolving fragmentation, not just within government, but within those actors that work with government, the donor community, the partner community, and also the private sector. It's good to see the Health Foundation of Nigeria is very active. We have PISHAN, we recognize and work with a lot, but there are also other entities that represent the private sector. How do we begin to manage that into a singular cohesive umbrella that can speak for the private sector to enable us to effectively engage in terms of ensuring that we have a good governance? There's also the thing of the community engagement. How do we make that happen? There's also the part of ensuring that we do not have multiple governance structure, which most times, even if we now said, okay, maybe at the end of this conference, there's a resolution, or there should be a standing committee at the national level to ensure integration of private sector participation in healthcare delivery in Nigeria. The next thing we'll call for is a steering committee, a separate governance structure from existing governance structure. So these are the kind of things that really lead to the issues with management and effective governance for health in Nigeria. Policy implementation, most of the things that are really the challenges there are the things we know, but sometimes we gloss over it because we do not focus on the detail of making it happen. One is even awareness. Lots of policies that we have, if we were to line list them and ask a quiz on it, many of us, even within the sector, are aware of these policies. Some of the policies we don't have the capacity to build. As I listened to Bastide from speaking about AI, I was just imagining that in 6 months' time, I'm definitely going to hear about an AI policy for health in Nigeria. Then we'll form a new governance structure to look after that. And then we'll assign people to do it that might not have the capacity to do it. So these are some of the things that we really need to look at. And these are really the areas where we can leverage private sector. But more important is how we use evidence. I think that's the biggest factors that we sometimes would think. And about how we do knowledge management and all of that and the rest. And more than everything else is sustainability. Sustainability has a lot to do with resources. And one of the things we always laud the private sector for is how they can effectively manage resources, how they can achieve more with lean resources. But then it comes with other questions that I think we'll go more into during the panel that I don't want to really preempt. But more importantly is how are we responding to all these issues of governance across the sector, and leveraging on the Honorable Coordinating Minister's remarks and the SWAP presentation. That is really Nigeria's response to governance for health. SWAP, sector-wide approach, bringing everybody under the same umbrella, formulating one big plan, setting out clearly national priorities, and asking everybody that is working or wishes to work in the health sector to follow that direction and continue to invest in that direction so that we can get to the right destination. So that is really how we are addressing that, because with that we address the issues of resource inefficiencies in terms of duplications, in terms of wastages, and sometimes we do these things not because we deliberately want to do it or out of corruption like people like to think, but often we don't even know what's going on. So right now, even at the level of primary health care, some of the big things we're trying to do now is primary health care revitalization, and other things we're training the health workers to be sure they are functioning properly at the front lines. And it's a nightmare just trying to coordinate what partners, trying to even get the information of which partner is investing where, asking the states, where are you already revitalizing? Asking the states that, oh, we have found resources to revitalize some facilities, please avoid them when you are doing your revitalization. They begin to see how significant it is to be able to effectively coordinate, and how important it is for us to really align and work under the SWAP initiative as we go forward in the conversation of how we onboard the private sector to help us deliver health. I'll just say these few things and pause there and hand over to the moderator for this panel to see how we can have this conversation further to highlight these issues. Thank you very much.
Thank you very much, Dr. Ogbe. As usual, it's always a pleasure to listen to you, and I will leave you a little bit of time to catch your breath. I'd have asked you the first question, which is on my list. But I think I'll jump first of all to Pishan and to Pelion. And I'd like to ask first of all from the representative of Dr. Titi, how do you think the private sector can contribute to more efficient resource utilization within the healthcare space? So from your own perspective as Pishan, we know you've done some work around, for example, adopt a facility, adopt a PHC and things like that. But how do you think the private sector can contribute, considering we're talking today about the SWAP initiative and trying to get one plan, one budget, one conversation, one of which we're having here?
Okay, many thanks for the question, and thank you so much, Dr. Ogbe, for setting the tone for this particular conversation. So in terms of private sector engagement, in supporting and making sure that resources are better utilized, I think it is very clear that we need to see health not as an emotional issue, but actually as a business case that actually translates to effectiveness or to improvement in a country's GDP if we're actually going to tackle and make more efficient use of the resources. One of the many successes that the private sector has, and a lot of times people want to associate with, is because for every investment, there is a clear business case as the reason behind what investments should go in and how those investments should be managed. And so a lot of times we do not tackle health from that systemic or from that organized approach. So it's important, you know, for us to see health as a business that could lead to returns on investment, be able to develop a business case around having health as investment opportunities and creating a whole value chain around the business of providing healthcare services. It's also important that for our health resources to be better managed, it is important to go in with the concept of sustainability. How do we ensure that the investments that we make in health, the decisions, the business decisions we're making for investment in healthcare is actually sustainable? How do we ensure that we also have the governance and accountability framework that translates to more efficiencies, reduces wastages, enhances better collaboration, and ensure that we get more money for every investment that we make, you know, in the healthcare? So it's important to begin to look at health from an end-to-end perspective as against looking at the fragmented approach, you know, that we have now. That way resources are more efficient and more.
Thank you very much, ma'am. I guess also maybe to Dr. Ngozi, Dr. Onya, would you like to share maybe an example of a public-private partnership that you've heard of or you've ever experienced or worked with?
Thank you very much for your question, because after her very brilliant answer, I didn't know what else to say. So thanks for that question. I would like to share my experience. I've been in a private-public partnership for the last 5 years with the Delta State Contributory Health Insurance Scheme. And I must say it's probably been one of the most rewarding things I've done. I have seen a transformation of a very underserved population. I have seen all the impact. And he talked about the social determinants of health. I remember the first time I started in September of 2019. The first thing that struck me was that the children there were malnourished. I saw malnutrition at a level I hadn't seen since the Civil War. That's the truth. In an agrarian society where I know they could actually afford to feed the children better, but they were just ignorant. So many things were done. The first thing I did was reach out to Mariam Uwais, who was my junior in secondary school, about school feeding program. So beyond just running a clinic, we did quite a bit about the social determinants of health. We educated the mothers on how, Madam, wait till you give your pikin today, Eba, in the morning, a 2-year-old child, why? So we tried to educate them about the, right kind of feeding for their children. We set up a comprehensive health center because ours is beyond private. I mean, it's beyond primary because we have a theater, an operating theater. And it's with a lot of pride and joy, I will say, in the last 5 years, we have had no maternal mortality, none at all. The few children who have died, I mean, the young man who works there is a young man, but he does amazing things to save lives. You know, the few children, the few perinatal mortalities we've had were inevitable. It was already too late, but the mothers' lives were saved, even if the babies were lost. I mean, they've impacted the society so greatly that when I threatened to pull out earlier in the year, for all kinds of reasons that Dr. Akpoveta knows, but I won't discuss. I mean, I got calls from the king of the kingdom, everybody, because it's such an important part of their society now, and it's extremely rewarding. We really can make a difference. Beyond the fantastic health outcomes we are having, we're providing employment opportunities for the indigenous. Everybody there is a local. So we employ only from the, and then with technology now, it's so easy to manage remotely. I hardly go to MI because of security issues, and yet it is running very well. All the efficiencies of the private sector were deployed, and we're having fantastic outcomes there. And I think, yeah, it can work. It's the way to go.
I think one of the things that the coordinating Minister of Health and Social Welfare spoke about was the efficiency that the private sector can bring into it. But we're so excited, can bring into health generally, and I think two of our panelists have spoken about that. But I'm going to take a look now at some of the people who I see as the visionaries of what actually happened in Delta State. That's Dr. Ben and, of course, Dr. Akpoveta, who is now midwifing it. And from your own perspective, Dr. Ben, it was like a pre-swap. You had swap in mind, I believe, when you came up with the Delta program. And how have you been able to ensure its sustainability so that now that Dr. Akpoveta is able to carry it forward? So from your own perspective.
Hello. Thank you very much. Yes, we had an advantage. The governor of Delta State was the chairman of the Senate committee that midwifed the National Health Act. So everything we did was in line with that act, and that's why it looks like it's synonymous with SWAP. So we had that vision, we had that plan. And the Delta State program is a perfect example on how the private sector should work with the public sector. It's also a perfect example on how things should not be done again. Because there were certain issues we had to navigate. It was more like learning how to swim in the middle of water, and that was a big issue. And pharmacists gave us a very good support, very good technical support. We midwifed it, but there were certain institutional challenges. The first was from BOI. I can quickly say that Delta State paid the first tranche of the 200 million to Bank of Industry, and they held the money for 6 months and said they thought we were not serious. That's the first example. That delayed that. And certain other institutional parts affected it to the fact that right now, I was a DG for some years. I struggled with it. Madam Onya says in her facility, zero maternal death. Actually, there were 15 facilities. Pharmacists did an impact evaluation report, and there was zero maternal death in the 15 facilities operating in the most remote part of the country. And that's just a phenomenon. But it now happens that, yes, on our own part, we had a transition plan. I mean, Dr. Akpoveta was the chairman, I was the DG, and we had a plan on that. But certain other issues came on board, and between the transition period, a lot of things went downhill. And the fact was that there was a deliberate attempt to kill the program call a dog a bad name to kill it, and we are now just trying to get it back to function, get it back to shape. That is why it looks like you see me in certain other fora. Is that same model NDDC has taken it up, and is actually that same phenomenon that I'm actually taking to Argonne across board. So Argonne is now currently seeing how they can partner with the private sector across board, because I would boldly say the most significant success factor of the Access to Finance program in Delta State was the fact that the local government chairmen were involved. We got them involved, they signed on it, they followed us to every facility, they took ownership, they guaranteed the patient load, and whenever we had challenges, they were there. So that's just the model that we're implementing across board. Thank you.
Thank you very much, sir. Dr. Robert, we saw the role of the community, and I'm wondering, how have you managed to sustain such a program? I mean, it's been a wonderful program in general. We have our complaints, of course, we would, but it's been a wonderful program in general. But how have you been able to sustain it after some of the transition challenges that were mentioned by Dr. Ben? Thank you, sir.
Hello. I think I want to first and foremost appreciate the organizers of this program. My two sisters, Dr. Pamela, Dr. Undide, I call her NN. Putting it together is a very fantastic decision. He has done one for us too. We did one in Transcorp here too, when we showcased the health. Coming back to Delta and this scheme, it's a unique one. First, let me say the Delta experience is unique, and this country should know about it. Former Governor, His Excellency Senator Dr. Kowa, talked very well about health insurance. And when he was forming it up, he appointed my humble self as the pioneer chairman, Dr. Ben as the pioneer DG. We were not civil servants. I'm a private sector person. Lagosians will say I'm a Lagosian. Ben was also in the private sector. And so the spirit of the private sector driven organization was the key, first and foremost, to success of Delta State. I, at the governance level, Ben at the operational level, we fused together like twins and we operated. There were challenges, but we faced it. There should be, among the things that you need to know about governance is that the leadership must have strong will, must be determined to succeed, and face all manners of challenges. Luckily, we have a governor that was ready for that, and two of us were also ready for that. And so we put it together. Coming to this particular program of access to finance, or what we call it, access to finance, Pharmacists Credit Fund brought a beautiful idea, we key into it, and we raised funds between us and Bank of Industry, almost $500 million, and we loan it to proprietors of well-known proprietors of hospitals, private sector-driven persons. And my sister here was one of them. You were there, Toronto and others. About 16 organizations borrowed between 20 and 40 million each to run a facility in hard-to-reach areas of Delta State, where you can take a boat for 4 hours before you can get to a village right in the middle of the ocean that have never seen a healthcare in their life. And doctors decided to go there, and I was very proud of them. And not only that, they borrowed 40 million, activated moribund facilities, ran it for 3, 4, 5 years, paid back the whole loan. As of today, we have recovered our 200 million. We have had interest on investment of about 100 million. And that's a public-private partnership. It's not probably the first type in this country. And so it was there. At the time Dr. Ben left and I left, the place was off about 4 months in the hands of people who doesn't have the spirit, the drive that we had. There were some challenges. But thank God, the present governor also found that there's need for continuity, there's need for strong governance, and he brought me back as the DG. And that straightened things up immediately. So the initial challenges are being corrected, and Odonya, I'm sure you're going to smile very soon. Yeah. But not only that, I'm happy that the country is drifting and asking questions from Healthcare Foundation. That what can we do together, public and private? Data is an example of that. Apart from the business aspect, we focus on how to reach areas. You are not going to come and stay in Warri, Sapele, Benin. You must go to the very far deep areas of Delta State. Like you said, where malnutrition is still a problem of today. And if you're ready to do that, please come to Delta. We'll have the money to give to you. We'll direct you where to go to. And there will be a coordination between the states. Thank you very much.
Thank you very much, sir. So I think there are a number of private sector partners in the room. Delta State have said they're open for business. I'm sure all the other states are also looking for opportunities. And so I'm going to actually direct this question to Dr. Ogbe. You've heard a little bit about, for example, things that have happened in public-private partnerships. We've had a very interesting discussion with the coordinating Minister of Health talking about SWAP. How can we align the policies with what the possibilities are for the private sector in this time of the sector-wide approach?
Thank you very much for that. I would say that there's not been a better time within the health sector to do this, to align really between the public and private sector. When the Honorable Coordinating Minister presented this agenda and with the follow-up present from SWAP, you saw clearly that one of the 4 pillars was basically unlocking the health value chain, which is essentially bringing in the private sector. And he did say something that was really apt, because sometimes we overlook it. Nigerian health sector is actually run by the private sector. From pharmaceuticals to all the medicines that are supplied, the marketing, the constructions, all the government projects and programs to revamp health, whatever it is done, it's all done by the private sector. And I think there have been also a lot of examples of PPPs, both within teaching hospitals, by governments, that are exemplary and can be copied. But I think where the gap is, and why we continuously, you see the private sector coming to say, let's get involved, it's really in the process of a mindset shift about how we think, how does the private sector deliver public services? And I was very, very happy to hear from Dr. Ona what she just presented, because that is really the line where government and health and private sector must come to transform how we leverage private sector enterprise and effectiveness to deliver health. And between what Dr. Ann presented from Vision, we must first think of health as a business that has to deliver outcomes, it has to have a good business case. But then, that was not a sustainable model that we can afford in our current state of socio-economic development. By the time we get much better and get to the kind of GDPs and per capita income like the US and other countries have, then you can do that purely. But also, we must also consider the part where we begin to look health as a social service. So there's a meeting point, and that meeting point is a hard point for the private sector to function in. And that's really where they must function in, where we now have what we know as social entrepreneurship, whereby the private entity goes into the business of health, but goes with a triple bottom line, not just profit and loss, but just like you said, you did mention money. It was Dr. here that came to start talking about money. You were talking about lives saved. So when you present to your board, when you give your report, it's not about profit or loss, but how many lives you've saved. So when you put yourself in that position, then there's talk of suboptimal, subnormal profits and things like that. So that is really where we need to go as government and private sector in terms of delivery, particularly at the primary care level. And that's really where we need the private sector to begin to see how they organize and begin to come up with a framework that will make that work, so that they still make some profit, but it's not all about the profit, but it's also about reporting about how lives are saved. And then how can we do this sustainably? Because most times for a lot of the ventures we see, there's a lot of subsidy that are inputted there that are not always sustainable. And once those subsidies are not available, then we run into challenges. So that's part of the opportunities too about the local governments really coming on board. Like I always tell Ben, local governments are coming, we see them coming, but we just have to midwife it in a manner that is able to come and actually deliver the expectations. Because when you now have more of the local government involved, then you can have these micro
right? So the kind of work Dr. Is doing is really not the work should be managed at the federal or state level. This is the kind of work that needs to be managed at the local government level when the resources are available, and there's the mindset of these triple bottom lines about life saved and things like that. So there is need for some regulation by the role of government. There are already lots of regulations, but the challenge is never the regulations, but how we implement it and getting people who are willing to work within that space to implement it without always just looking about what the maximum profits are. So I think this is really where we need to have that dialogue and have the private sector really lead forward to say, particularly with umbrella bodies such as Vision and the Nigerian Health Foundation, to say there's this framework where private sector could operate in small groups, in small units, and take help to manage health and the front lines with this approach that you get rewarded not just because of how much profit you make, but how many lives you saved. Thank you.
Thank you very much, Dr. Ogbe. I really like, you kind of like itemized three things. You talked about profit and loss, which for the private sector is really key, or you can't be sustainable. But you also talked about access to finance, which is an important part of ensuring that you are able to run a sustainable program. But I'm going to take this question now to Dr. Ben. Dr. Ben, as the advisor to Algon now, and I know you're doing a lot of work, what are you going to tell them to do from now so that the private sector will be involved in primary healthcare delivery? And now I'm talking about actual service delivery, which is where some of the products, we've kind of got the drugs, the commodities, okay. But now about the actual PHCs, what are you going to be advising them?
First of all is to have a clarity that Algon, Association of Local Government Councils, is a third tier of government with a constitutional responsibility to ensure availability of primary healthcare services that meets the quality and the needs of the people. And so the entire governance structure in line with SWAP. So first of all, what's their governance system, accountability system, stakeholder engagement. But the first thing which I told them is this. We keep assuming that local government is responsible for primary healthcare centers. No. Local government is responsible for primary healthcare service delivery. And it covers both the private, the public, and the PPP. So first of all is to have that governance system that puts all into a basket and have other mediums to ensure that the people have both the access and also the other social determinants of their health are covered. So Algon is also looking at agriculture, sanitation, and all that ensure that people are able to receive care. And I take a cue from one of the issues Dr. Onya kept telling me about, that the facilities she's having, the people don't have access. And right now, Algon is being told, you need to provide accessible routes to these facilities. You need to ensure that the workforce are sustained in terms of their career pathway, in terms of encouraging them to go to the rural facilities. And so there's a large gamut of what needs to be done. But the important thing is that Algon has initiated a revitalization and operationalization program for primary healthcare service delivery, and it's a big project, and they are committed to it, and they are going to deliver it in line with the SWAP National Health Sectorial Investment Initiative. Thank you.
Thank you very much, sir. So maybe to Dr. Apobeta, how would you feel this will be operationalized? I mean, now you've been running this as the state. I know the local government, you've been carrying them along. But how would you operationalize this? You know you want the private sector to come in to support the work that's being done. Algon are ready and waiting, probably waiting for funds to start flowing in that direction. How would you operationalize involving the private sector in the light of the changes that are taking place, and now the funds may not necessarily come to the state?
I think it's something we've done much pretty recently, and therefore it will not be difficult. First, what we did was to determine a moribund health facility, whether primary health care center or built by one of these donors, Chevron, and so on, and we're not operating. We meet with the communities, encourage them to release those facilities for us to loan them, so to say, to an investor. Some local government chairmen signed off straight away because most of the facility they had in their locality were not having personnel. They were not having drugs. They were not having resources to run them. And so they were happy to see that for the first time, a medical doctor will run a health center in their locality. Yes, 90% of primary health centers have no medical doctors. They don't even have qualified nurses, probably just one, and then others are low-level professionals. So when you meet a facility and talk to the operator, the owner, and say, look, we're going to bring a team of medical personnel to run this facility for your people to receive good care, they are very happy to key in almost immediately. And there are so many out there. We have so many primary health care. In Delta, we have 460-something primary health care centers. And I can say probably only 2-3 of them have doctors. And so if I bring 20 doctors to Delta State and I say, sir, I want to bring a doctor to your community to run this facility, I can tell you immediately they will sign in. So operationalization is very easy. We bring the private sector with its wealth of experience, with personnel, with resources and facilities to activate a facility is a go-go and a win-win situation for everyone. I can assure you of that.
Dr. Nya, would you do it again?
Yes, I will. Yes, I will. Differently, but yes, I will.
I think that's something. So it may look tough. I think that's what we're trying to say. But we see the impact as providers, and so we would love to do it again. But finance is key. I think that's what
let me correct that.